Bon dia a tothom. La veritat és que ens fa moltíssima il·lusió avui trobar-nos aquí després de tants anys que no ens hem pogut abraçar, no ens hem pogut dir bon dia, i això a la soci és una cosa que la trobem molt a faltar. Per tant, estem molt i molt contents d'avui trobar-nos aquí. Evidentment, vull agrair la presència del Govern de la Generalitat, la senyora Meritxell Budó, que està aquí com a govern, però amb nosaltres per una cosa més entranyable, perquè és patrona de la Fundació d'Hemofília. Sí que hi ha una cosa que avui no vull deixar de recordar, que avui és la 14a edició, però a les 13 primeres ens va acompanyar una persona que sempre ha estat al nostre costat, és el Miquel Rutllan, tots el recordareu. L'última vegada que el vam veure va ser en aquesta mateixa sala, quan encara no podia venir ningú, però ell sí que va estar amb nosaltres i malauradament al cap de pocs dies va morir. El Miquel Rutllan va estar amb nosaltres des del primer moment. Ha estat una persona que ha fet fàcil les coses que eren difícils. Mai a la vida va deixar de costat el col·lectiu. Sempre que vam tindre un problema va estar amb nosaltres. Jo crec que era una persona que ens estimava de veritat. Era una persona que mai ens va deixar, ni en els moments difícils, ni en els moments molt difícils. Recordarem, sobretot l'Edu i jo, que vam estar molt presents, que en la denúncia que es va fer per l'hepatitis va ser la persona que ens va defensar amb més vehemència. I el col·lectiu no t'oblida, Miquel. Bueno, la vida ens porta a aquestes coses, no? Se'ns en van amics, molt amics, però ens fa, vinga va, busquem un altre carinyo, busquem una altra persona que ens pugui ajudar així. I en el seu enterrament se'ns va acostar el Xavier Trias i ens va dir: Oti, sé que us ha deixat una persona que us estimava molt. Estic aquí pel que faci falta. Ja sabeu com som la soci. Doncs sí, ens fa falta un patró. I qui millor que el Xavier Trias, que és la persona que va impulsar la fundació. La nostra fundació va ser impulsada pel Departament de Salut i els primers diners van ser donats per ordre del doctor Trias, del conseller Trias, perquè comencéssim aquesta andadura en moments molt difícils en què la Fundació només podia donar ajuts a les persones afectades per la sida. Per tant, avui molt feliços que el Xavier Trias un moment o altre arribarà. I després, permeteu-me, l'última jornada que ens vam trobar estàvem tots molt tristos perquè el nostre president estava, al meu entendre, empresonat injustament. I avui no hi ha el Miquel Rutllan, però hi ha l'Edu. I això ens omple d'alegria. Bueno, escolta, la sòcia és això, són sentiments també, si no, no seríem nosaltres, no? Però bueno, hem de disfrutar de la jornada, hem de disfrutar molt. Avui ens parlen persones de reconegut prestigi, que no cal presentar-les perquè ja són gairebé amics. Marina, Brian, Michael, per nosaltres ja gairebé són amics. Són persones que estan al davant de tot de l'hemofília, que tots seguim a les xarxes socials perquè és la forma d'estar més i més informats, i avui tindrem, jo crec que el privilegi de tenir-los aquí entre nosaltres, i per tant moltíssimes gràcies i esperem que vingueu cada any. Jo crec que, sense més, intentaria tirar endavant. Només dir-vos una cosa, que la jornada, potser a la meitat, fem un petit salt i el que són pregs i preguntes de la primera sessió potser passaran al final totes juntes perquè hem tingut la grata sorpresa que el conseller Argimon ens passarà a saludar. No podia, tenia un matí molt complicat, però just ahir ens va dir que tindria que ens vindria a saludar i que vindria a estar una estona amb nosaltres. Per tant, quan ell arribi, ens adreçarà unes paraules i el que farem segurament és passar el prec i preguntes que ens farà la Olga Benítez de la Vall d'Hebron, s'ajuntarà amb el doctor Mateo de Sant Pau, sortiran tots dos i intentarem fer-ho junt, si us sembla. Doncs res, escolta, aquestes jornades per vosaltres i el que més il·lusió ens fa és que avui estigueu aquí i complim la sala. Benvinguts i té la paraula la honorable Meritxell Godó, patrona de la Fundació. Endavant.
Bé, moltes gràcies, presidenta, estimada presidenta i companya de patronat, membres de la Junta i del patronat, de l'associació i de la Fundació de l'Hemofília, doctor Macris, doctor McHoney, doctora Carrasco, amigues i amics, permeteu-me primer de tot que m'adreci a vosaltres, també com a patrona de la Fundació i acompanyar també les paraules de l'OTI cap al doctor Rollan i també cap a la incorporació de l'honorable doctor Trias, que penso que també és una incorporació del patronat brillant i que ens ajudarà a poder continuar fent aquesta immensa tasca que feu totes i totes junts. Jo el que us voldria primer de tot és felicitar per l'organització d'aquesta 14a jornada d'actualització sobre l'hemofília, que després d'un temps de pandèmia en què les jornades les vàrem haver de fer en línia, jo recordo que l'any passat em vaig estrenar amb unes jornades que vàrem haver de fer online, malauradament, però les vàrem fer perquè vosaltres teniu aquesta capacitat de fer les coses i, per tant, malgrat les dificultats que la pandèmia ens va portar, les jornades es varen poder treballar. Ara hem pogut recuperar aquesta presencialitat i fer-ho en un espai únic, emblemàtic i meravellós com és aquest recinte modernista de Sant Pau. He de dir també que és un luxe que en aquestes jornades puguem comptar amb ponents de reconegut prestigi internacional que han vingut personalment per exposar-nos temes relacionats amb l'hemofília que de ben segur seran d'interès per totes les persones que estem aquí presents. I permeteu-me també que us digui que és molt necessària i vital, i això ho vull destacar en aquestes meves primeres paraules, l'existència d'entitats com les vostres, que treballeu per aconseguir la millora integral de la qualitat de vida de les persones que pateixen l'hemofília o altres coagulopaties congènites a Catalunya. I també permeteu amb el vostre treball la seva integració total a la societat. Perquè a banda de l'atenció mèdica i la investigació sobre les malalties, és molt important aquesta tasca d'acompanyament als pacients i a les famílies. I sovint, o malauradament, aquesta tasca d'acompanyament és inassolible pel Sistema Nacional de Salut, és inassolible pels seus professionals. Ara, sí? Sí. Ha de recaure en les entitats de pacients que de forma voluntària, no ho oblidem, de forma voluntària, dediqueu el vostre recurs més preuat, que és el temps, a ajudar a totes aquelles persones que hauran de conviure tota la vida amb una malaltia. Però a més, el paper que juga una entitat com la vostra, una entitat dedicada a les persones i que viuen una necessitat de salut, va molt més enllà de l'acompanyament de la persona amb la malaltia i la seva família. El paper de les entitats també és clau en l'augment de la visibilitat de la malaltia a través d'accions de difusió i de sensibilització a nivell comunitari, la promoció d'hàbits saludables i d'educació per la salut, el foment de la recerca, el treball col·laboratiu amb l'administració i el sistema sanitari per tal de millorar sistemàticament l'atenció sanitària a les persones que el presenten i, com us deia, la visibilització d'aquestes malalties per aconseguir més recerca, més innovació, millors tractaments. També us volia traslladar un altre missatge. Des del Departament de Salut, que avui em toca aquí representar a l'inici d'aquestes jornades, però que de ben segur us ho repetirà després el conseller Argimon en la seva salutació d'aquí una estoneta, des del sistema de salut, des del Departament de Salut, creiem que per millorar el sistema sanitari cal fer-ho també des de la participació, ja que només des de la participació aconseguirem una salut més robusta, corresponsable i assertiva. De fet, només a través de la participació es pot traslladar l'experiència vital de viure, d'ajudar a viure o de tractar una malaltia i traslladar aquesta experiència vital a les polítiques de salut. En aquesta línia ens calen molts actes com aquest d'avui per tal d'enfortir la relació entre els professionals mèdics i els pacients, ja que aquesta coneixença, aquest treball conjunt, aquest enfortiment d'aquesta relació és el camí per poder anar cap al que és les decisions compartides. La presa de decisions compartides, penso, un element bàsic en les polítiques de salut centrades en les persones. I això ens generarà, com us deia, un sistema de salut més assertiu, més respectuós, més lligat a la realitat. En definitiva, ens apropa també a un model d'excel·lència i de millora continuada que ens garanteix la millor atenció possible. Gràcies a aquesta voluntat de tots, l'administració, els pacients i entitats, avui penso que ja podem dir que podem gaudir d'una bona qualitat assistencial pel que fa al tractament de pacients amb coagulopaties congènites. Actualment a Barcelona tenim 3 centres, l'Hospital de Sant Pau, el de Sant Joan de Déu i la Vall d'Hebron, que ofereixen una atenció integral i uns estàndards de qualitat que cal mantenir i cal ampliar. Però encara hi ha camí a recórrer, encara tenim molta feina a fer i aquí, amb l'OTI i amb els membres del patronat, en parlem sovint i de fet en aquest darrer patronat que vàrem fer ara fa 10 dies tot just, ho vam tornar a posar sobre la taula, que és la necessitat de poder disposar del registre de coagulopaties congènites que des del Departament de Salut treballarem al costat de la Fundació i de l'associació per tal que això sigui una realitat. En aquests moments, us he de dir, ho tenim sobre la taula, ho estem treballant perquè s'acabi consolidant com una realitat aquest registre de coagulopaties congènites. Són deures que tenim l'administració, els tenim a sobre la taula i el nostre compromís és poder-ho resoldre el més aviat possible. Per tot això, pel que feu, pel que heu fet i pel que seguireu fent, us en dono les gràcies i desitjo que aquesta jornada que ara iniciem sigui tot un èxit.
Seu, ara baixarem quan ell acabi. Gràcies. Presentes? El doctor Parra ens farà una mica la presentació ara de la jornada.
Bon dia, Oti, bon dia, Meritxell. Hola, bon dia a tothom, benvinguts a aquesta nova edició de la jornada d'actualització en hemofília. Aquesta és la jornada número 14. Com ja sabeu, la pandèmia no ens va deixar fer les jornades des de fa 2 anys de manera presencial. L'última vegada, ja com s'ha comentat, la vam voler al mes de desembre fer-la presencial, però la pandèmia, la onada Omicron, ens ho va impedir. Però ara finalment podem tornar a fer una jornada presencial i com deia l'Oti, podem estar ben contents de poder retrobar-nos un altre cop. Des de la Comissió Assessora Científica hem preparat un programa que creiem que és força interessant i que esperem que us agradi. El programa l'hem dividit en 2 parts. Una primera part amb la que es parlarà sobre aspectes directament relacionats sobre el tractament de la hemofília i d'altres coagulopaties, i una segona part més aviat destinada a parlar sobre aspectes organitzatius i funcionals tant de les unitats d'hemofília com de les societats d'hemofília. Per parlar d'aquests temes contem amb 3 ponents, com també ja s'ha presentat l'Oti, el doctor Mike Macris, el senyor Brian Mahoney i la doctora Marina Carrasco. Tots 3 són ben coneguts de nosaltres, però permeteu-me que faci una petita presentació de tots 3. El doctor Mike Macris és el director de la unitat d'hemofília de l'Hospital de Sheffield. També és professor d'hemostàsia i trombosis a la Universitat de la mateixa ciutat i és membre de diversos grups de consell editorial sobre diverses publicacions científiques en l'àrea de les coagulopaties. El senyor Brian Mahoney va ser president de la Federació Mundial d'Hemofília i actualment és el president executiu de la Societat Irlandesa d'Hemofília. També és una persona amb una àmplia experiència amb el món de l'hemofília i tots dos són persones reconegudes internacionalment. Finalment, la doctora Marina Carrasco, hematòloga, metge adjunt de la unitat d'hemostasi i trombosis d'aquí, de l'Hospital de Sant Pau. Com ja he dit, el programa es divideix en dues parts. En la primera part, el doctor Macris ens parlarà sobre els aspectes actuals del tractament i, sobretot, com serà el tractament en els propers anys. Tots sabem que hi ha noves molècules, noves aproximacions terapèutiques i ells ens explicarà una mica quin impacte o què s'espera d'aquests nous tractaments. El senyor Mahoney ens explicarà precisament d'un d'aquests tractaments, de la teràpia gènica, com a persona que ha rebut aquest tractament ja des de fa algun temps i ens parlarà de la seva visió sobre el resultat i les implicacions d'aquest tipus de tractament. Finalment, la doctora Carrasco ens parlarà sobre la coagulopatia amb la dona i les implicacions amb el dia a dia, un tema que no se solia parlar en reunions, però que darrerament té més presència en les reunions i en els mítings internacionals. Havia un torn de preguntes, però l'Auti ha comentat que aquest torn de preguntes es farà al final entre la doctora Benítez del Vall d'Hebron i el doctor Mateo de Sant Pau. I amb la segona part que parlàvem, el doctor Macris tornarà a parlar i ens explicarà quina és la visió que ell té sobre el futur de les unitats d'hemofília. Si aquestes unitats d'hemofília han de canviar la seva estructura, com canviaran amb l'impacte dels nous tractaments i quina és la perspectiva de futur d'aquestes unitats. També el senyor Mahoney ens parlarà sobre la seva relació que ha tingut en la relació de la Societat Irlandesa d'Hemofília, amb la relació amb el govern irlandès i amb les autoritats sanitàries del país per tractar els temes que afecten a la comunitat hemofílica. Jo vull agrair als tres ponents les seves presentacions, però també, com ha dit l'Auti, vull especialment donar les gràcies al doctor Macris i al senyor Mahoney per la seva disponibilitat de venir a participar en aquestes jornades totes les vegades que li hem demanat, i aquesta no és la primera vegada. Són dues persones reconegudes internacionalment, amb una agenda molt apretada, però sempre que els hem demanat han volgut participar amb interès, amb entusiasme i de vegades per davant d'altres compromisos internacionals. És per això que vull donar especialment les gràcies a tots dos. I això és tot per la meva presentació. Espero que us agradi la jornada, que sigui del vostre interès, i ja li passo la paraula al doctor Macris perquè ens presenti la seva ponència.
Thank you very much for the invitation to give this talk. Thank you to the local team for their hospitality, which is unparalleled. It's really a great pleasure to be here, and it's a great pleasure to be here face to face. You know, we are all human beings and we miss interaction at the face-to-face level. So my talk today is going to be about the current and future treatments of inherited bleeding disorders. And I'll cover conditions, not just hemophilia. Here you see my conflicts of interest. I lead a group that involves monitoring adverse events, so that's why there are lots of companies at the bottom, because they're funding the monitoring of adverse events. And we have, that's a European group, we have one of the centers in Barcelona, but now that I know how the hemophilia care is in Barcelona, expect to hear from me, because we want all the centers to be part of this monitoring of adverse events. So, this is what I'm going to cover today. This is a summary slide, and I'll show it again at the end. And basically, what it tells you is what we have now and what is probable going to happen in the future. So if we go on the left, this is what we have currently as our treatments for hemophilia now. So as you can see, we have factor 8 and factor 9 that are either made from plasma or recombinant. And we also have the extended half-life product. This means that the products have to be given less frequently. These are widely available, and I know anybody with hemophilia in this room is probably has had exposure to these products. If you have an inhibitor, the current treatments are recombinant factor 7A, Novo7, or activated PCC, which is fever. The big development that happened since the last time I was in this city in person to give a talk to this group is the introduction of the bispecific antibody or Hemlibra, and we'll talk more about this. In terms of the future, you can divide them into 4 groups. And people with hemophilia, it's amazing to see this degree of innovation for one genetic disease. And you may wonder, why are there so many new treatments for hemophilia? It's because hemophilia is an expensive disease to treat, and it's affected by one gene. So it's potential to develop new products. So there is a new extended half-life product for hemophilia A in development, probably be here in the next couple of years. When we went to the pediatric hospital here in Barcelona to see them yesterday, they had some patients on this product in the clinical trial. So they're already in this city, but they will become more widely available in the next 2 years. There are new bispecific antibodies, cousins of Hemlibra, going to be available. And again, we heard yesterday, these are already available in Barcelona in clinical trials, and patients are on them. There are rebalancing therapies, and I will explain to you how these work, and gene therapy will focus a bit more with the talk from Brian. So all of these are on the horizon, but actually, if you wanted to take part in a clinical trial in Barcelona, you probably could have any of those treatments today. So this is the history of hemophilia in one slide. Really, no treatment before 1965 other than a blood transfusion. Cryoprecipitate was introduced in 1965, and factor concentrates in the early 1970s. And then we have the disaster of the early 1980s with HIV and hepatitis C. But the amazing thing of viral inactivation cannot be overstressed. So in 1984, all products were transmitting hepatitis C and HIV, and within a year or 18 months, basically that was eliminated because it was recognized that you could eliminate these viruses. And then in the 1990s, we had the recombinant factor 8 and factor 9. The extended half-life products were introduced about 7 years ago, and emicizumab or Hemlibra was introduced in the last 2 to 3 years. It varied by country to country in Europe, but it's now becoming more widely available. So when it comes to choose a product, you really have just 4 key things to look for. Efficacy, does it work? Safety, is it safe? Is it convenient, and what is the price? On the top right-hand corner, the regulators, you would expect the regulators not to approve a product unless it works and unless it's safe. And in this population, safety is key. We have to be sure that all products are safe as the number one issue. And then we come to the bottom, and that is price versus convenience. there is going to be an issue, because sometimes if you're not getting any bleeds with one product, how much more do you pay to get a more convenient product? So the next 3 slides summarize the products by specific conditions. So in hemophilia A, we have the standard half-life products, the extended, and emicizumab, as I mentioned. DDAVP is a really cheap product, but it only works in mild hemophilia. And in clinical trials, we have the ultra-long factor VIII, the other products that were in my original slide. And at the very bottom, I've put in brackets 2 products that are in theory in development, but I personally do not think they will be introduced because of issues with side effects during the clinical trials. So I don't think the implantable spheres or the subcutaneous factor VIII is going to be the answer. In hemophilia B, it is very similar, except that Hemlibra, the bispecific antibody, does not work in hemophilia B, and we do not have an equivalent. So if you have hemophilia B, the current treatment is with factor IX. But the plus side of that is that the extended half-life factor IX is dramatically better than the extended half-life factor VIII. And there are new treatments in development for hemophilia B as well. In terms of hemophilia A with inhibitors, we've had FIBA and the Novo7 for 30 years. 7-FACT is a different version of recombinant factor 7, was introduced in the last year. And the big difference, if you have hemophilia A with inhibitors, Hemlibra has been the most dramatic improvement imaginable. These are patients who used to still have 50 bleeds a year, and you start them on Hemlibra, and 80% do not have any bleeds at all. It is a dramatic improvement. Hemlibra for inhibitor patients, to me, is a no-brainer. It's going to be the treatment of choice. In clinical trials, we've got the rebalancing agents that will work. We've got the bispecific antibodies. And gene therapy has already started in clinical trials in patients with inhibitors and hemophilia. Always when we give talks, we tend to forget that there are lots of other diseases that affect people that are not hemophilia. These are bleeding disorders that do not affect hemophilia. So in the middle, so on the left is the different rare diseases. In the middle is the current products, and on the right is what is in clinical trials. So I'm not going to go through each of them individually. For example, the bottom one, Glanzmann thrombasthenia, is a very rare disease. It's probably, in a city like Barcelona, there will be 100 times less patients with Glanzmann thrombasthenia than there are with hemophilia. So, and the treatment currently is platelet transfusions or Novo7. However, there is quite an interesting antibody treatment given under the skin once a month. It's not Hemlibra, but it's the same idea that probably is going to be available for these patients. If you go for the factor 7, factor 10, the rebalancing therapies will work. Von Willebrand disease, if you have type 3 von Willebrand disease, there are some new treatments possibly going to be introduced. Hemlibra, it's already been shown to work, but in a small number of patients, and there is a new molecule that may have a role. Works. Yep. Okay. So this slide you probably cannot see, but you just need to see the colors. And this is what the UK has been using over the years. On the left is 1995, and on the right, 2019. In these these gold bars is plasma-derived products. In blue is recombinant. In green there is the extended half-life products. And what you're saying, basically, the plasma-derived products in the UK are not widely used. The recombinants are, and the extended half-life products are increasing. If this was continued, it would be big changes because the extended half-life products will be the majority of the products, and Hemlibra will have an impact. And the same as here, the plasma-derived reducing, the extended half-life having much more impact because they're truly very long. So what is the difference between standard half-life and extended half-life? So if you have hemophilia A, you give 3 injections a week for prophylaxis. If you have the extended half-life product, it's twice. So this is a difficult concept for patients to understand, is the half-life. What it means, how long does it take for the product you just given to yourself to only have half of it? So if you've given yourself 100%, how long will it be to get to 50%? So for factor 8, standard is 12 hours, factor 9, 18 hours. So when we talk about the extended half-life products, the factor 8 goes from 12 to 18. So it's a slight increase, but it's not a dramatic increase. For hemophilia B, however, it goes from 18 to 90, and that is a marked increase. So what it means in hemophilia B, you go from 2 injections a week to 1 injection a week. So really, the standard or extended half-life, you can think of them as very similar. It's just which one do you prefer? Because the efficacy is the same, the safety is the same, the price is different. The convenience is different. The convenience is different. One of them you give less frequently. Okay, so I'll next talk about Hemlibra, which has been the biggest impact over the last few years. So this is a slide that shows how Hemlibra works. So what happens in the clotting system, we've got the cell surface, and we've got the factors that are different factors, and they're going like this, and they're occasionally meeting. But we have some factors that bring them together. So in factor 8, which is what is available in hemophilia A, is missing in hemophilia A, brings these factors 9 and 10 together. So if you have no factor 8, these two do not come together very often, and you don't get any clotting. So what Hemlibra does is an antibody, and one part of the antibody is against 9A, the other one against 10, and it does the same function, and it just brings these two factors together. So this is a summary of all the papers that have been published to date on one slide, and I'll take you through it to understand what it shows. Annual bleed rate. What the annual bleed rate is if you're a patient, how many bleeds per year would you have, taken on a population basis? So is it 0, 1, 2, 3, up to 10 there? So those of you will remember who are patients, if you have no treatment, annual bleed rate will be, if you're not on prophylaxis, annual bleed rate will be 20 to 50. With Hemlibra, this is after you start Hemlibra, this is in the number of weeks. So in the first 6 months, the average was 1.9, less than 2 bleeds per year. But as it went on, the average is less than 1 bleed per year. So on average, if you put 100 patients in Barcelona on Hemlibra, they would have less than 1 bleed per year each. And on the right-hand side, these numbers is less reliable because there were few patients going there. So people on Hemlibra can still get bleeds. They treat them with factor 8 in the usual way, but the number of bleeds is a lot less. So Hemlibra is available for treatment of hemophilia A with or without inhibitors. It's given under the skin once a week, once every 2 weeks, once every 4 weeks. All of them work equally well. The once a week and once every 2 weeks work equally well. If you're giving it just once a month, it may not work as well, but it's not dramatically worse. So in our center, the majority of patients are once every 2 weeks. When it was introduced, it was not used in very young children. So anybody less than 1 year of age, it was not being used. But what actually happened is something dramatic, and it started being used in children under 1 year of age. So people were skeptical. Will it work if you give a treatment to a child with hemophilia under 1 year of age? And everybody thought probably won't work, they're too young. But actually, it turned out it does work. So people now are starting on Hemlibra children with hemophilia A at less than 1 year of age. And the data are really pretty good. And as you can see, I put there 75% are bleed-free. This is a complication that people need to be aware that the clotting tests in someone on Hemlibra are normal, but that doesn't mean your clotting system is normal. And that's important because I've heard of a patient in Spain, not in this region, a patient in Spain, who went to another center because they were, for some reason, there. They went to the hospital, they were on Hemlibra, and they had a serious injury. So when they went to the accident emergency department, they had a blood test, and the clotting tests were normal. So they said, well, the clotting tests are normal, you can go ahead with the surgery. But it ended up being a very big problem. So what Hemlibra does, it converts you from having severe hemophilia to mild hemophilia. And other bispecific antibodies are in clinical trials, other treatments like this. And as I mentioned already, they are being used in clinical trials in Barcelona already. So as you can imagine, once another product comes on the market, the price is going to reduce. Okay. Changing to the new ultra-long factor VIII treatment. And this is not extended half-life that you're all used to. This is even longer half-life, and it's a complex figure. But basically, factor VIII is the blue part here, and the extended half-life that we've got now have this bit there that makes them longer, and this product basically supercharged by having 2 other parts to extend it. So during the clotting system, these bits are chopped off and you're left with this bit, so it lasts longer. To show you how long is shown here. So I showed you earlier that when you give standard factor VIII, it's 12 hours, the half-life, or 18 hours for the long-acting. So what you're seeing here, concentrate on this column. So if you have an injection of this product once a week, at 7 days, you're still having 18% factor VIII. And that's really impressive. On the right-hand side, you see what happens if you have the current product and the long-acting ones. And basically, if you want to get to 1% with the old products, it takes a day. With the new products, it takes 2 weeks. So how does that mean? What does it mean to you? It means if you're on prophylaxis, you can have it once a week. If you're having surgery, you can probably have surgery with 1 injection of factor VIII. That's what it will mean, which is quite impressive. Okay. I'm going to overload you with information, and I apologize for this. It's the only way I can give you a talk in 30 minutes. The next group of slides I've got is about another way of treating hemophilia. And it's a way of treating hemophilia that none of you, or none of us as doctors, thought about 5 years ago. And essentially what happens in hemophilia, in the body, we have factors that promote clotting and factors that cause bleeding. And traditionally, we've only concentrated on one side of the balance. And if you think of here, the balance is, you have as many blue balls as yellow balls or gold balls. So in hemophilia, you're missing some of the blue balls, so the clotting, the balance is towards more bleeding. And what we do these days, until now, with treatment, we add more blue balls to balance the cascade. There is another way of doing it, however, if you think about it, and that's to take away these balls on the right and to rebalance the system. And there are 3 groups of treatment. There are actually 4 drugs, but one of them has got 2, in development. Doesn't matter how they work, the principle is the same. You're taking away the balls on the right. They're all given under the skin, most of them once a month. They prevent bleeds, but you cannot use them to treat an acute bleed. So, do they work? Yes, they do work. However, I told you, in hemophilia, number 1 priority is safety. Okay, we are not going to go back to the early 1990s again. We cannot go there. We have to consider safety. So the companies are investing huge amounts of money on this, but safety has to be the number 1 priority. Why am I stressing that? And it's an odd thing to talk to people in this room, that there is a possibility that we are stopping bleeding at the expense of causing thrombosis, and that cannot be acceptable, because the current treatments do not cause thrombosis. Well, they can cause it, but incredibly rare. So if you're on factor VIII, standard factor VIII, if you're a patient and you live 1,000 years, you're going to have a possibility of having 1 thrombosis with the current treatments. But if you look at the data, are not reported in the same way here, because there have been only 30 cases ever with emicizumab. However, if you look at these bypassing agents that I've just shown you, the rebalancing therapies, one of them, there have been 5 cases in the clinical trials. In the clinical trials, only enrolled about 150, 200 patients. One of these trials stopped because of thrombosis. One was suspended. So I'm personally so far not convinced this group of therapies are definitely going to be introduced. They have to be shown they're safe before we accept them. So in the last part of my talk, and Brian is going to talk to you about his own experience on this, I'm going to talk to you about gene therapy. And gene therapy has always been almost like science fiction. It's going to be in the future. It's going to be introduced one day. But the future is now. So this year, I am personally convinced we're going to get these products licensed. Gene therapy in hemophilia will be licensed. And the problem healthcare system will have is going to be the ability to pay for it. But it's important to appreciate what gene therapy is. Gene therapy is gene addition. People with hemophilia in the audience are missing a gene, and you're giving the gene back to the patient. They're not changing the genes in the patient. So if you have hemophilia and you have gene therapy, you can still transmit it to your daughters. Okay, that's important. It's not changing the gene of the patient. So this is what you do. You take the factor VIII and IX gene, you take a virus, you remove all the bad things about the virus, and this one used is called at the moment, they're all based on this, adeno-associated virus, and you inject it, and it goes to the liver and makes factor VIII or factor IX. Very simple. However, there's big science behind it. What happens if you're going to have gene therapy? Well, having the gene therapy takes an hour or half an hour, and that's it. However, the whole area around it is so complex. So you really have to start talking to your team about, is it going to be the best treatment for you at this stage? And it's going to take months and months, because this is a one-off. You're not going to get a second chance of this. You're going to get one chance to have this gene therapy with this method. And then you have it infusion, and then there are loads of visits. You can visit the center twice a week for several months. Are you able to do that if you're working? I'm not so sure. It's going to be challenging. There are issues during this. And then you're going to, at the moment, a few years ago, they said they were going to be followed for 5 years, patients. Now they're talking about 15 years. My view is, once you have gene therapy, you're followed for life. So this is what happens. This is for hemophilia A. You get injected, and the factor VIII goes up, goes down a bit with time. And in hemophilia B, again, you have the injection, it goes up, and it stays up. What most of you in the audience do not know, do not look at graphs like this. So you see this, and when it's imported, when the companies report it, they show you something like this, and it's really impressive. Especially if they don't show it like this. They show it the way they want to impress you. However, what this shows, this is the factor IX activity, and it goes from 0 to 100%. And this is week 1, and this is week month 18, 6 months. No, 18 months. What this shows you, this is the average. So if you treated all your patients in Barcelona with this, their average will be 35%. However, what this hides is these long bars. And this is the variation. So some patients, you have gene therapy, will have a level of 0 or 1%, and some will have 90. And you cannot tell as a patient which one it is. So on average, it will be 35, but as a patient, you cannot tell that. So variability is key. The other issue is durability. How long does it last? Well, in hemophilia A, it's predicted to last for 8 years. In hemophilia B, at least 10 to 20 years. The longest hemophilia B patients are a group in London that have been going for 12 years, and their levels haven't fallen. So we know at least 12 years for hemophilia B. So if you have hemophilia A, will you go for gene therapy? It's a big discussion you should have with your center, because you know, the current treatments are pretty good. Will you go for this as a one-off shot? Or would you wait 5 years, 10 years to get something that is probably going to be better? That's going to be an issue for you. That's not going to be an easy one. What are the long-term issues? It's very sexy to go for something new. Yeah? New iPhone comes up. You find the people outside the shop to buy the new iPhone. However, what happens if they tell you that's the only mobile phone you're going to get in your lifetime? Would you want that if, say, you had one of those, flip phones without, a tiny screen, and it was 20 years ago? If you wanted a mobile phone and you knew that in the future may be better, would you go for that one? I'm not so sure. You would want to see what is in the future and which was better. And you want answers to, things like this. Is there a risk long-term of cancer? And what is the competition of gene therapy? Well, we've got alternatives, that are giving you 70% bleed-free at the moment. We've got the Hemlibra, we've got the injections, we've got the standard factor VIII, and in hemophilia B, you've got the alternative injections. So it's a difficult question. And Brian will give you his views, because he had to think about all of this when he was going for it. And what about other groups? At the moment, gene therapy is only for adults. And gene therapy for children, it's probably going to come in a different way, using lentiviruses. And it's starting in India. In some people have already antibodies to the virus that does the transmission, so that will not be possible at this moment to have it, except people with antibodies are already in clinical trials. People with inhibitors, the trials have started. And what about people with bleeding disorders other than hemophilia? What happens if you have factor VII deficiency, or 5 deficiency, or 10 deficiency? They're very rare. Will it come? Well, this is my view, okay? These clinical trials have not started. But I believe that it will happen for those patients. But I believe the way it's going to happen is going to be different. The companies are there to make money, okay? They have fund, people invest in them, and their role is to make money. And they're going to go for diseases. There are lots of patients. They're going to charge a lot and make money. I'm not saying it's a bad thing because we're getting a lot of innovation. However, if you have one of these diseases that are in 1 in a million or 1 in 2 million of the population, they're not going to make money from those. So these are the type of conditions that we're talking about. The companies will not make a profit, and they're not going to go for it. The technology is available today if you wanted to do it. So I think what's going to happen, well, I suspect what's going to happen, the technology will be approved, like the virus. This bit there is going to be approved. And then you have a cassette of the different ones being put in it, and is the technology that is approved rather than the individual drug. And you're going to put it in, and it's going to work. And I think the way it's going to be funded is by publicly funded. So it's possible that the European Commission will say, okay, for factor 5, you go to Milan and have this. For factor 7, you go to Madrid and have it, or Barcelona, or Brussels. And that's what's going to happen. And interestingly, people in the audience may not know, for Glasgow thrombocythemia, there's a group in Spain that actually has developed it already in vitro, in the laboratory. It hasn't been tried in a patient yet, but they're looking, they cannot do it on their own, they'll need investment, but that may happen. So I think, do not despair if you have got one of these disorders. I think gene therapy will come. So, coming to the end, you saw this before, and we're ending up in hemophilia with a paradox of choice. If you have anything, if you have a condition, there is only one treatment, you really feel what this says, you're feeling a bit depressed because you haven't got a choice. But as soon as you have a choice of another product, you're feeling a lot happier. And that's what, this is a business book, it's nothing to do with hemophilia. So as soon as you have a choice, it makes you happier. So your happiness rate as you have a choice goes up. But as you have more and more choices, actually, it doesn't do this, it does that. Because you are finding it difficult to choose. How do you choose amongst all of these? And you will need, listen to other people, listen to your health professionals, and come to a choice. So this is what you saw at the beginning. We have very good standard extended half-life products, bypassing agents, Hemlibra, but there are many more in development, and they're coming. This is going to be here in 2 years. I'm not sure about these ones. The alternatives are going to be here. The rebalancing therapies may be introduced, they're shown to be safe. Gene therapy is going to be licensed this year. So these products at the moment in Barcelona are available to you as part of clinical trials. However, I think for most of these will be available to you in the next, I would say, well, anything from 1 year, 2 years, 5 years. So in summary, we currently have many safe and effective treatments. There are multiple products in development. Gene therapy is likely to be licensed in 2022. Deciding which to choose is difficult, and non-hemophilic bleeding, i.e. the rare bleeding disorders, unfortunately those patients have less choices, both now and in development, but you have not been forgotten. People are thinking about you. And finally, if you want to be updated, follow me on Twitter, either me or Brian. And we tweet a lot about these things. And I know many of the people in the audience because I recognize your faces. And you've already told me, follow me. So thank you for your attention.
Bon dia. It's difficult to follow Mike, but I will do my best. Okay, so I'm going to talk in general about the kind of decision process for gene therapy and also mix that in with my personal experience of gene therapy. So despite the many wonderful treatments that Mike spoke about, despite the many advances, there's still a degree of unmet need in hemophilia. Joint damage, poor health-related quality of life, functional impairment, social isolation, acute and chronic pain, psychological difficulties, and lack of personal productivity. These can all be factors for some people with haemophilia. And when we look at the current treatment options, I mean, we currently have really good treatment options. We have regular IV infusions of factor concentrates or extended half-life factor concentrates. We now have the subcutaneous emicizumab for factor VIII deficiency. And then when we look at gene therapy, it's also worth noting that probably only 40 to 50% of those with severe haemophilia will be eligible for AAV gene therapy. Those who are not eligible currently include children under the age of 18, those with pre-existing antibodies to the AAV virus, apart from one hemophilia B trial where that's not an exclusion, those with a history of inhibitors, in some trials those who are HIV positive, and anybody with active liver disease. And also you have to look at other considerations. What's your proximity to a specialist centre? What about the presence of local expertise for follow-up of the hub and spoke model? And in Europe, EHAD and EHC have agreed jointly that gene therapy should be delivered through a hub and spoke model. So there'll be perhaps a couple of expert centres in each country, which will be the hubs, and then the other centres will be spokes. So the benefits and risks, I'm not going to dwell on this slide because I'll go through stuff more in detail, but you know, there's a lot of benefits, there's a lot of risks. I'll let you look at that for a moment, but I'll come back to that stuff. The kind of concerns that the patient community would have. So, well, maybe it won't work. And as Mike showed in the graphs, you get an average, but you can't predict beforehand whether or not it will work for an individual. If you get an immune response, and it's quite common to get an immune response, if you think about it, you're injecting in a very large amount of virus, your liver cells can react to this and give an immune response. Now, it's not a serious immune response, but the problem is that if it's undetected, you can lose the factor expression, you can lose the benefit of the gene therapy. So in that situation, they must go in quickly with steroids, hence these constant visits for blood tests in the first number of months. And I think in terms of expression, there's a wide variability in expression, and it's not predictable. So the key thing is, as Mike said, it can be from 0% up to well over 100%, but you can't say beforehand, as an individual, what your expression will be. Cancer, there's a theoretical risk that if the vector is integrated or some of it's integrated into your own DNA, does that insertional mutagenesis increase your risk of cancer? And then economic. I mean, will you have access to gene therapy? Will governments pay for this? And I think we're doing a lot of work at the moment on economic modelling, on new payment models, and also, frankly, managing the expectations of the gene therapy companies. This is not going to be a lottery win for them. In terms of patient community concerns, I've heard a lot of concerns about the impact of vector shedding, although that is for a limited period of time. It is an irreversible therapy. Once you take gene therapy, it's there in your system for life. Whether it works or not, it's irreversible. You hope to get reasonable expression. Retreatment, well, you can't currently be retreated with the same vector, and realistically, you can't be retreated with any other AAV vector. So currently, as Mike said, it is a one and done opportunity to have this. And in terms of cross-reactivity, it appears to be the case that if you get one AAV vector injection, that it really gives you antibodies that will cross-react with all the others. So this is a one-time opportunity. The kind of decision drivers. I think a lot of this comes down to your experience, your lived experience with haemophilia. So for any individual thinking about this, what kind of decision drivers would they be looking at? Well, their annualized bleeding rate and their bleeding phenotype. You know, how many bleeds do you get per year? Do you bleed a lot? Do you bleed little? What's the existing state of your joints? Current activity levels and barriers to increased activity. So I'm not talking about replacing Lionel Messi on the Barcelona team. I'm talking about, even though I'd love to do that, I'm talking about reasonable, normal activities, cycling, walking, tennis, whatever. Needle phobia. Do you have needle phobia or poor venous access? the fatigue of living with severe haemophilia. At an EHC meeting a couple of years ago, one gentleman in the audience said that he would consider gene therapy because he would like to try life without severe haemophilia. I thought that was interesting. And also a big factor is your access to existing therapeutic options. How good is your current therapy? Now, if you're in a place like Barcelona or a Western European country where you've got access to good treatment, that gives you different options. I can tell you that if I was doing this talk now in Delhi, in India, and he said there's a gene therapy which has some risks and so on, but it could give you the potential of a 5% factor level for 5 years, they would jump up and down to get hold of this because their options are limited. So we are in the fortunate position of having these options and looking at this in a very methodical way. What kind of decision drivers depending on age? Well, younger adults, I guess the ideal population for gene therapy perhaps would be a newborn child with severe haemophilia. You give them gene therapy, it lasts a lifetime. But you can't give it to children because, of course, the livers keep maturing. And if you gave AAV gene therapy to a child, the liver cells would turn over and they'd lose the gene therapy. So for younger adults, you would expect younger adults, a generation who've grown up with prophylaxis, with good access to treatment, that they might have very good joints. The gene therapy then could continue that, could increase their quality of life, could give them the possibility to be more active, maybe more opportunities for employment or travel. I don't know what it's like in Barcelona, but in Ireland, a lot of people, when they finish college, or they're 20, 21, 22, they want to go to Australia or Canada for a year or two. They want to travel. And gene therapy would certainly make that easier. For example, you can get into Australia with severe haemophilia for a year. They won't allow you to stay for a second year because you'd be seen as a potential burden on the healthcare system. Gene therapy would change that. For older adults who may already have significant joint damage, it might offer an improvement in chronic pain, because if you get a decent level of factor expression, then perhaps that would prevent any subclinical bleeding, give you the ability to be more active with your family and friends, and more freedom from having to think about your haemophilia. Children, I think, obviously would be an ideal target for gene therapy. But as Mike said, maybe you have lipid nanoparticle delivery systems, lentiviruses, some integrating gene therapies in the future. There might be options. I think we will see trials in children between the age of 12 and 18 in the next couple of years. But I think it'll be a long time before we start seeing this in those under 12. And some of the parents have said to me, when they heard that I'd taken gene therapy, we're very glad to hear that. We'll see how you get on. And then we'll judge for our child in the future. Early adapters. Mike talked about the iPhone. When the new iPhone comes out, the kind of person who's in the queue outside the Apple store on the first morning would be an early adapter. So you have some early adapters who always want the latest treatment. They want it as soon as it's licensed. You have those who are very cautious, who might wait and see for a considerable period of time, or who will not take the option. So we certainly have some members, when we talk to them about this, say, oh no, I'm not interested in gene therapy, it's too exact, no, I'll leave that. I'm very happy with my current treatment or my current options. And then you have others who are very keen to have gene therapy. A lot of people are in the middle. They'll say, oh, very interesting, I'm going to keep an eye on this, look at what's happening and look at the data, but I mightn't be one of the first to have it. I'll wait a couple of years. And that's a reasonable expectation as well. It's a reasonable attitude. And I think this trend may be more apparent in factor VIII, not just because of the different results of the factor VIII gene therapy compared to factor IX, but because in factor VIII you have emicizumab as an option. And certainly quite a few of our people with haemophilia who are on Hemlibra are saying, well, I'm very happy with this, so I'll stay on Hemlibra for the next couple of years and keep an eye on what's happening with gene therapy. And I think the uptake will increase when it's licensed, when there's real-world evidence of safe, stable, and hopefully more predictable factor expression, and also agreement on which assay to use to measure the expression, because there's two assays you can use and they give you different expression. So my own decision process, well, as the leader of the organisation in Ireland, we had been bringing companies over to Ireland since 2013. We had our first talk for our members on gene therapy clinical trials in 2013. So nearly all the companies came over. We would have meetings with the companies, with the clinicians. I organised these meetings. We did these discussions. I followed the science avidly. I was very interested in this. So I guess I persuaded myself that it was a good idea. And we've been discussing participating in clinical trials for several years. We'd never quite got over the line. So, one trial happened and then there was a delay with the regulatory authority, and this one was going ahead, and then they decided not to do phase 1-2 in Ireland. So eventually I persuaded myself, based on the science, based on my experience of haemophilia, based on the data that I saw, and based on a careful personal analysis of the potential risk and benefit, that I wanted to try it. And I also, frankly, part of it was I also wanted to lead. So I knew that if I tried gene therapy and we got going in Ireland, then this would change the conversation. So I was the first person in Ireland to get haemophilia gene therapy. In fact, they had a new clinical trial unit, and I was the first person in that clinical trial unit to be treated with gene therapy for any condition. So they were much more excited on the morning of the infusion than I was. My treatment history with haemophilia, well, I have a lot of family history with haemophilia. I had 4 uncles with severe haemophilia. I had 2 younger brothers who died of bleeding when they were in childhood. I have a younger brother now with haemophilia. Several cousins with haemophilia. There were enough of us to form our own chapter. I think in my family over 3 generations, I counted 17 people with severe haemophilia. So in childhood, I had no access to treatment. Many bleeds into joints and muscles, nosebleeds. From age 14 to 17, I was treated with plasma, which involved a 200-mile journey to get plasma and then 200 miles home. From 18 to 41, I was treated with PCC, or plasma-derived factor, and then from 41 to 58 with recombinant factor 9. At the age of 58, I actually did a clinical trial for another recombinant factor 9 because I was able to get higher doses. And then from 59 to 62, extended half-life factor 9, which was very beneficial. And then at the age of 62, I decided to try gene therapy. I've had, obviously, given that history of bleeding, I've had an ankle fusion, a fasciotomy in the forearm, and a knee replacement. So my rationale, well, before the gene therapy, I was being treated with EHL factor 9. I was on prophylaxis every 10 days. My venous access was okay, it wasn't great. My annual bleed rate was 0 to 1. So I wasn't bleeding a lot. I had a knee replacement in 2018. And obviously I had pre-existing joint damage with a degree of chronic pain. So what was my rationale? Well, I hoped for a factor expression ideally between 20 and 50%. However, I was fully aware that I could stay at less than 1%, I could get 100%, I could get 150%, that it was unknown, but that was what I hoped for. I hoped for a decrease in chronic pain in my target joints. Obviously, I was looking forward not to have to take frequent IV prophylaxis infusions. Perhaps a degree of mental freedom from haemophilia, which I realized would be less for me given my job. And also I wanted to try life without severe haemophilia. And again, earlier, before I started the trial, I took part in a process called CoreHeme, where we came up with consensus outcomes for gene therapy. So what were the really important outcomes? The frequency of bleeds, factor activity level, which we felt was the most important, duration of expression, chronic pain, a utilization of the healthcare system, which is a nice way of saying cost, and mental health. But I think many of us with haemophilia, certainly, and we published on this, felt that factor expression was the most important, followed by duration of expression. Those two were the most important outcomes. So my expectations going into this, well, I hoped for at least 10 years. I looked at the data from London, from the earlier gene therapy trial, so I hoped for at least 10 years of expression. Ideally, I would have liked a factor expression between 20 and 60%. I hoped for less pain in my damaged joints, perhaps due to reduced subclinical bleeding. In terms of mental health, I thought, well, I'd be free from the burden of regular IV infusions, and actually free a reduced time dealing with my own haemophilia, thereby allowing me to concentrate on haemophilia generally for our members and for the community. My annual bleed rate, well, it was already very low, so I didn't expect that to change very much. Factor use, ideally I'd want to use factor only for major trauma or for surgery. And my activity level, I hope to increase my physical activity level and fitness. Of course, I had concerns. Transaminitis. So this increase in the liver enzymes, which can cause you to lose the gene therapy. So that was a concern. That if that happens, you have to take steroids, perhaps for a number of months. And I was so concerned about that in fact, the protocol for my gene therapy involved weekly blood tests for the first 3 months. And I said to them, I want twice a week. I want the liver enzymes checked a second time every week, so I do not want you to miss an increase in the ALT. Because if you had a normal liver enzyme on a Monday and you tested again the following Monday, in the meantime, they could have gone up and you could have lost a significant amount of the gene therapy. So I think, obviously, the theoretical risk of cancer from insertional mutagenesis and the risk of losing the expression that I may have achieved, and also the fact that there might be no improvement in chronic pain. So, but basically going to this, I looked at my entire life's experience with hemophilia, and thought, you know what, I'm going to try this. I'm going for this. But it was a very methodical and carefully thought out process. So this is the morning of the gene therapy. This was February in 2020, about 2 weeks before lockdown. My timing was impeccable. I got in just before COVID, 2 weeks before lockdown. That's at the clinic with my wife and with the doctor, and just before they give you the infusion, they say, by the way, this is your last chance. Are you absolutely sure you want to proceed with this? Now, I actually said no just to wind them up because everything was ready, but no, I proceeded. So the process is not difficult. This is the gene therapy in the brown bag at the end. It gives a whole new meaning to brown bag lunch. And this is the infusion. It took about 80 minutes. It's a simple intravenous infusion. Now, I was quite relaxed, and the two nurses were there, and they were very pleasant. But you get less relaxed when you look around and you realize that there's a crash team outside with a crash cart, and the hospital director is there, and they have the hospital PR person there. And there was about 15 people outside the room because they'd never had a gene therapy before. So they were making me a little more anxious, but I was very relaxed on the day. It went fine. In terms of managing expectations, so you have to realize your factor expectations may not be met. It's not a genetic cure, but it may be a phenotypic cure. It won't reverse existing serious joint damage. My ankle is fused, my knee is replaced, that's not going to be reversed. Gene therapy itself won't make you more active or get you off the couch. You actually still have to get off the couch and move. It doesn't mean you can undertake very risky activities or sports with total impunity. So, boxing, rugby, they're still going to be on the no list. So in terms of the mental health implications, I think that there's been a significant amount of anxiety and depression associated with hemophilia. Now, thankfully, I don't suffer from that. I think I've got a very positive attitude. But gene therapy, they expect it might reduce that and could lead to positive feelings of joy, ease of living, or a new outlook on life. But also then people need emotional support. There were reports, especially from the USA, from the early clinical trials, of people feeling a loss of identity and a loss of community. And hemophilia is part of who I am, and I don't want to lose that. Now, I didn't really get that. I haven't felt any loss of identity, and I think part of it may be because they wrap up too much of their identity in having hemophilia. You're a person with hemophilia. Hemophilia is not the entire person. But secondly, I think some of them perhaps cut themselves off from their community and their friends with hemophilia when they didn't need to. I think one thing that did resonate with me, one man, and it wasn't actually gene therapy, it was somebody who switched to Hemlibra and his annual bleed rate went way down. And he said after a couple of months on Hemlibra, and he was doing really well, he started to feel a bit depressed because he said, I'm 45, and why couldn't I have had this quality of life for the last 40 years? So it's what I call loss of past opportunity. So there are, it's not simple. I think, and in fact, thinking about all these issues, I did recommend to our own centre, which they implemented for the trial, that everybody going to a gene therapy trial should have an initial discussion beforehand with the centre psychologist, and actually note that down. Because how can the centre tell afterwards, if they're trying to measure outcomes, if your mental health has changed, if they don't have a baseline? So my outcome to date, my factor expression has been very good, sort of 30 to 50%. Last week, I was tested last week, I was 52%. I'd hoped for 20 to 50, so my target was met there. I'm very happy with that. Chronic pain has decreased in some target joints, although my ankle is giving me trouble. But that may be due to the gene therapy, but it also may be due to the time since my knee replacement, because it's now a couple of years, so the knee has got stronger. I had no bleeds for the first 2 years, and I had an ankle bleed for the first time 2 weeks ago. It was like an old friend that you don't really want to see again coming to visit. I've had treatment was required only for a biopsy, for a steroid injection, and also for that ankle bleed. I am healthier, but that's partially due to gene therapy and partially due to the lockdown, because my life before lockdown was crazy. When I was preparing for the gene therapy trial, I sat for a couple of hours with the research nurse negotiating visit dates because I was traveling so much. And then COVID happened and there was no travel for 2 years. And actually that was very beneficial. I was traveling so much that I think in 2019 I did 44 trips outside Ireland, and during lockdown some of my friends were phoning my wife to ask how was she coping with having me in the house all the time, and suggesting to her that she might drive me to the airport for lunch. I don't have any treatment remorse. I'm glad I made the decision. I made the decision knowingly and having fully considered it, but I'd also prepared myself for a suboptimal outcome and said, look, if that happens, I've made this decision on all the available data that I have at the moment, and if I don't get the outcome I want, I'm not going to regret that. Because, of course, it doesn't cut off your previous treatment options. So what was unexpected? Well, the impact of the weekly blood draws on my iron levels. I developed an iron deficiency because they were taking 130 mils of blood every week. That's equivalent to donating a pint of blood every month, which you can't really do. So my iron level went down. I definitely got a degree of mental freedom from having to plan activities and treatment for travel. Well, first of all, because I wasn't traveling, but you're not packing as much factory you might. And frankly, on most of the trips I've done the last year since we started traveling, I haven't brought factor with me. My veins have recovered. My veins are very good. I've suffered no loss of identity. The mental freedom for me is less because of my roles with the Irish Society, the World Federation, European Hemophilia Consortium. So hemophilia is basically my life. So the mental freedom for me is less. But certainly I do not have to spend as much time thinking and planning about my own hemophilia. Having said that, as Mike pointed out, the number of visits to the centre is huge. The follow-up is huge. But frankly, when you're on a clinical trial, you get very good clinical care. Now, this was exactly 1 year after my gene therapy. I was walking in the Dublin Mountains with my wife and kids. I'm a very awkward person, okay? I drop things. On this occasion, I dropped myself. I was climbing over a low stone wall about this high, and I slipped and fell onto some rocks. No bleed, nothing. That was stunning. And a couple of weeks later, I dropped a 2-kilogram weight on my bare foot, and my foot started to swell. I put some ice on it, and it went down straight away, no bleed. So that was just amazing. Because you all know in this situation, you rush home, you take factors straight away. So I think it does help you to start developing the future, which is thinking about a hemophilia-free mind, where you have more freedom from hemophilia, where it becomes a part of your life, but doesn't consume too much of your life. Also, I used my gene therapy when gene therapy is licensed, we'll have to look at the reimbursement, the economics, the payment models, and we're working on that. But also, we want to increase public awareness of this, awareness in the political system. So when the gene therapy trial started, we publicized this in the media. And then when the results came out, I also publicized the fact that I'd taken part in the trial. I was greatly amused by my local newspaper in County Kerry. They didn't care that I had gene therapy, just that I was a Killarney man and had gene therapy. So it's very parochial. I had a lot of media coverage over the last couple of years. In terms of informed consent, this is an irreversible one-off option, but you can return to your other treatment. So it's not like you're going to develop an inhibitor to the other treatment. So if it doesn't work, you can go back to factor or emicizumab or whatever. You have to fully consider all the pros and cons before enrolling in a trial or licensed therapy. There's significant monitoring required in the first year. So anybody thinking they're going to take a licensed gene therapy and it will free them from the centre, absolutely not for the first year. You're in there more often than you probably ever have been in your life. I think you need to obtain information from the society, from publications, from the website, from meetings. You need to engage fully and repeatedly with the clinical team. This is not a single conversation. This is a number of conversations at different levels over a number of months. And I think you need to understand why you want gene therapy, what your expectations are, and how you'll feel if you get a suboptimal outcome. And if you get married in Ireland, part of the wedding vow is that you say that this is not to be entered into lightly or inadvisedly, but reverently. But to me, gene therapy is a tougher decision than marriage, because you can get out of a marriage and you can do it more than once. You can't do that with gene therapy. Once you have gene therapy, it's in your system for life, even if it doesn't work, and it's irreversible. I'm not suggesting you get out of marriage. Marriage is very good, but this is a very serious decision. And just comparing A with B, the results to date, and I've taken some of the data here from the BioMarin trial and the CSL Unicure trial that Mike referred to earlier. So if you look at likely durability, Mike said 8 years, I think. So it's 5 to 8 years for hemophilia A, probably more than 10 years for hemophilia B. At the recent WFH Congress, hemophilia A gene therapy was referred to as a lengthy vacation from treatment. Factor expression, there's a wide variation, but there's less variation in B. Lack of expression. For the hemophilia A, there were 9%. 9% of the people in the phase 3 trial did not get a factor level that they could really measure, any increase that they could measure. They were below 3%. And a total of 12% were less than 5%. So let's say 1 in 10 will not get an increase in their factor level. With hemophilia B, 4% didn't get a factor level, but there was a clear rationale for that. One of them actually had a very high antibody titer. Now, this is the gene therapy that having pre-existing antibodies did not prevent you from using it, but this person had a high titer. And the second person who didn't get an expression, actually he only got a partial dose. He got an allergic reaction during the infusion. Steroid use for factor VIII gene therapy, about 80%. For hemophilia B, less than 20%. Cost for hemophilia A will be high. Cost for hemophilia B will probably be higher, because for hemophilia B, factor 9 is more expensive than 8. And in terms of eligibility, I've done my own figures on this, and I reckon about 44% of those with severe hemophilia A and 48 to 60% of those with hemophilia B will be eligible. The role of the patient associations, and I know I'm running short of time. The role of patient associations, they have several important roles here. And really, let me just summarize to say, look, this is a very complex therapy, but we have to get the information out to people. It's a complex decision, but you can't produce a very glossy, very detailed scientific publication and expect all your members to read this. So we have to get the information in terms of sure science and glossy publications, websites, infographics, videos, social media. We have to make it comprehensive but also comprehensible, and we have to give the information to our members in the format that they use. There's no point, if my children had hemophilia and I produced a beautiful booklet on gene therapy, there'd be no point in giving it to them, because they consume social media and Facebook and Instagram. So you've got to get it out in those media as well. And this is some of the information that's out there at the moment. On the bottom right, this is the Irish Society's hard copy version of the EHC Novel Treatments Review, which comes out twice a year. It's a superb publication, and it's 50, 60 pages, and it lists everything. Now, most of our members won't read that. We actually produced this primarily for the healthcare workers. But it's a great basis on which you can then take this and you can make simplified versions. You've got to do infographics, podcasts. The EHC have a new app as well. So you've got to have all of these up there. The other thing is that this area is changing so rapidly that if we produced a booklet tomorrow on hemophilia gene therapy, in 3 months' time you'd probably have to do a new edition, because things are changing so quickly. So you also need to use media that you can update frequently and without too much difficulty. So my conclusions: you need to be aware of the known unknowns and set your expectations accordingly, and be prepared for a range of outcomes. So durability, how long will it last? We don't know. Variability in factor expression. Predictability, what proportion of people may or may not get a response. The short and long-term safety. And affordability, even if you're convinced that it will work for you, will your healthcare system pay for this? And we definitely need new payment methods. And I think for most European countries, my expectation is we'll have an annual payment model linked to performance and linked to outcomes. You need a clear process of informed, multi-stage, shared decision-making This is not a decision that your doctor can make for you. It's a decision your expert doctor makes with you. The information has to be delivered at the appropriate level for each individual, and I think it will take multiple consultations over a reasonable time frame. We're already looking at this. We're planning out workshops. We're planning out a whole information system for people where, they come to meetings, they come to workshops, they discuss it in groups. I see one of our roles as a patient organisation is to get our members ready for the consultation with the expert clinician, but even that will be a multiple consultations. So we need to optimise the collaboration between the centres and the societies on education, on the hub and spoke model, and really work together to make sure that when this is licensed, that it is available in the best possible way. And that's my Twitter handle. And on the left actually is a live television interview I did about 2 weeks ago on my gene therapy experience. But what's ironic is what you can't see is behind the sofa are my crutches, because that was just at the time I had the ankle bleed. I didn't mention that. I didn't want to spoil a good story. But the fact is that even I had a bleed after 2 years. Okay, it's annoying. It was surprising. But it hasn't changed my mind. I think I made the right decision for me. My rationale was clear, and I don't have any regrets on this. And so thank you very much for your attention.
Buenos días a todos. Quiero agradecer a la asociación la posibilidad de dar esta charla. La verdad es que dije un sí inmediato, pero ahora he de decir que estoy bastante abrumada, ¿vale? Por compartir cartel con el doctor Macris y el señor Mahoney. Pero bueno, haremos lo que se pueda. Entonces, el tema de mi charla que me propusieron es hablar sobre la mujer y sus trastornos hemorrágicos. Y lo primero de todo, pues la primera pregunta que nos podemos hacer es ¿y por qué hablar de la mujer? Entonces, en 3 diapositivas os voy a decir en qué nos diferenciamos. La primera diferencia sería esta, que mi jefe, el doctor Mateo, todavía no entiende cómo puede ser. La segunda diferencia sería esta, que quizás es un poco más discutible. Pero hablando en serio, la diferencia real que tenemos hombres y mujeres es el aparato reproductor, ¿de acuerdo? Entonces, mi charla se diferenciará en 2 bloques. Un bloque hablaré de lo que es la parte más propio del sangrado en la mujer, o las cosas más relevantes y más específicas de la mujer, que sería el sangrado menstrual abundante, que ya hablaré más adelante, las posibles situaciones de cara al embarazo y otras situaciones. Pero en un primer bloque, primero haré unos comentarios sobre la enfermedad de von Willebrand, un poco orientadas a la mujer, las portadoras de hemofilia y otras coagulopatías, ¿vale? Entonces, empezamos. Sobre las coagulopatías, los 3 grupos así más importantes o más frecuentes son las portadoras de hemofilia, la enfermedad de von Willebrand y otras coagulopatías que son más minoritarias. Respecto a las portadoras de hemofilia, pues todos sabéis, no hace falta que os lo explique, que es que va ligada al sexo, que de un papá pues con hemofilia, pues las niñas serán portadoras obligadas de hemofilia, y de que una mujer portadora, pues la mitad de su descendencia, sean niños o niñas, pues serán portadores, ¿vale? Entonces, primero de todo, ¿y por qué pasa esto? Porque uno puede pensar, o hace años se pensaba, que los únicos que sufrían hemofilia y que sangraban eran los hombres, que las mujeres eran unas meras portadoras y que no tenían ningún problema. Pero esto no es verdad. También otro pensamiento que uno puede hacer es que como la mujer portadora tiene un gen sin la hemofilia y un gen con el gen afecto, que es el de la hemofilia, pues un gen compensa al otro y entonces pues no tiene por qué sangrar, ¿vale? Pero esto no es real, no es así. Existe un fenómeno que se llama el fenómeno de lionización, ¿vale? Que es un fenómeno que, bueno, se llama así porque quien lo descubrió, una señora que se llama Mary Lyon, ¿vale? Por eso le pusieron este nombre. Y este es un fenómeno que ocurre porque en una célula no pueden coexistir dos cromosomas X, ¿vale? Y uno de ellos se apaga, ¿vale? ¿Y cuál se apaga? Pues es al azar. En cada célula al azar se apaga o el bueno o el que tiene la hemofilia, ¿vale? Entonces, un ejemplo visual de esto pues son estos gatitos. No es que me gusten mucho los gatos, pero aquí os los enseño. ¿Qué le pasa a estas gatitas? ¿Vale? A estas gatitas le pasa que el color de su piel viene definido por cuál de sus cromosomas X se ha apagado, ¿vale? Entonces, esto es el fenómeno de lionización y en la hemofilia pues pasa esto, que al azar en cada célula de la mujer portadora se inactiva uno de los dos cromosomas X, ¿vale? Y cuando se mira al microscopio lo que se ve es esto puntito de aquí en el núcleo que se llama corpúsculo de Barr. Bueno, un poquito de ciencia. Este es para que lo veáis, este es un estudio de ya hace muchos años del doctor Rosendahl en el que miró los niveles de factor 8 en mujeres que tenían el gen de la hemofilia, que eran portadoras, y mujeres que no tenían, ¿vale? En esta columna de aquí son el nivel de factor que tenían estas mujeres, ¿vale? Está puesto en unidades mililitros, si multiplicas por 100 es el valor, ¿vale? Entonces, bueno, las mujeres portadoras de hemofilia tienen un nivel más bajito que las que no son portadoras, que pueden ir entre el 40%, el 50% como media, ¿vale? Pero que, bueno, si una mujer tiene muy mala suerte y se le inactiva, porque esto es el azar, es como quien le toca la lotería, todos los genes que son sanos, que no tienen el gen de la hemofilia, pues quizás eso se llama lionización extrema y esta persona tendrá los niveles que pueden ser de una hemofilia leve, moderada o incluso severa, ¿vale? O luego puede haber quien tenga mucha suerte y que tenga unos niveles pues muy normales del 140%, ¿vale? Entonces, resumen, una mujer portadora de hemofilia puede tener cualquier nivel de factor. Os pongo esa tabla aquí para que recordéis que la hemofilia leve son valores por encima del 50% hasta el 40%, la hemofilia moderada de 1 al 50 y por debajo de 1% es una hemofilia severa. Pero ¿qué pasa en una cirugía? Porque una mujer puede tener un nivel de 40% o 45% y ser considerada normal. ¿Pero qué pasa en una cirugía? Pues hay que tener en cuenta que para ciertas cirugías mayores, cirugías muy importantes que se saben que ya de normal sangran mucho, pues se recomiendan unos niveles de factor pues hasta el 80 y el 100%. Y en una cirugía menor, pues niveles del 40 al 50%. ¿Vale? Y esto os lo muestro aquí para que veáis que es así. Este es el mismo estudio, ¿vale? En el que se preguntan a las mujeres si han tenido sangrados en intervenciones quirúrgicas. En rojo son las mujeres portadoras y en azul son las mujeres que no tienen el gen de la hemofilia, ¿vale? Pues, como podéis ver aquí, muchas más mujeres tienen problemas hemorrágicos en cirugías respecto a las que no son portadores de la hemofilia. El asterisco quiere decir que la diferencia es valorable, ¿vale? Entonces, a un porcentaje elevado necesitan tratamientos para poder controlar la hemorragia y un pequeño porcentaje respecto a las no portadoras necesitan incluso más transfusiones de sangre, ¿vale? Y con las cirugías pasa, pero es que con cosas más menores, por ejemplo, una extracción dental, ¿vale? Pues también pasa. Las mujeres portadoras de hemofilia tienen más sangrado, necesitan volver a ir al odontólogo o añadir tratamientos farmacológicos y en cirugías que ahora los que son más, yo creo que ahora ya los pediatras no hacen tantas amigdalectomías, pero los que tenemos una edad, antes hacían muchas amigdalectomías, pues también las mujeres portadoras de hemofilia tenían muchas más complicaciones hemorrágicas y necesitaban más frecuentemente terapias o reintervenciones o más terapias adicionales. Moraleja, que todas las mujeres portadoras de hemofilia deberían conocer su nivel de factor 8, porque a lo mejor puede tener un 20, un 40 o un 80. ¿Vale? Bueno, y ahora pasaré a hablar de la otra enfermedad, otra coagulopatía más frecuente, que sería la enfermedad de von Willebrand. ¿Qué es la enfermedad de von Willebrand para quien no la conozca tanto? Mira, esto de aquí sería el polímero, el multímero de von Willebrand, que va por el plasma, que cuando hay una lesión en una superficie, en un endotelio vascular o donde sea, las plaquetas, el von Willebrand ayuda primero a que las plaquetas se unan al endotelio, a la superficie dañada, y luego también ayuda a que se unan entre ellas. Y luego aquí encima actúa pues todos los factores de la coagulación y todo esto. Si esto no pasa porque el von Willebrand está disminuido o funciona mal, pues ya empezamos la casa mal, ¿no? Ya no, el tapón hemostático ya empieza mal si el von Willebrand ya no funciona bien. Y entonces pues se puede sangrar. Es el trastorno hereditario la coagulopatía hereditaria más frecuente. Se calcula que hasta un 1% de la población lo puede tener. Hay diferentes niveles o intensidades. Puedes tener una hemofilia leve, un von Willebrand leve o un von Willebrand más severo. Se calcula que 1 de cada 10 personas afectadas de enfermedad de von Willebrand no son diagnosticadas porque son formas muy leves. Y la mayoría hay mayor prevalencia en las mujeres, y se piensa que esta mayor prevalencia en las mujeres es porque cuando tienen la menstruación y tienen una coagulopatía, pues sangran, que esto lo veremos más adelante. Y los hombres, pues si nunca se someten, tienen un von Willebrand leve o moderado y nunca se someten a ninguna cirugía, nunca entran en una situación de riesgo, igual no se diagnostican hasta edades muy avanzadas. Bueno, no lo he dicho, pero bueno, es una enfermedad, a diferencia de la hemofilia, es una herencia autosómica dominante o recesiva y que la pueden tener tanto hombres como mujeres, ¿vale? En diferentes grados de intensidad. Bueno, y el tratamiento del von Willebrand pues es un poco el mismo también que el de la hemofilia, pues desmopresina, encefibrin, que ya lo conocéis todos, o concentrados de factores. Otras coagulopatías que también pueden dar problemas hemorrágicos y que son algo más minoritarias, pues bueno, pues tenemos los déficits de factores. Quien haya venido por la unidad y ha visto nuestro reloj. Los déficits de factores, pues esos son los factores de la coagulación, ¿vale? Y se pueden tener déficits de todos los factores de la coagulación, del 1 que es el fibrinógeno, el 5, el 7, el 8 y el 9 que es la hemofilia, el 10, el 11 y el 12, ¿vale? Entonces, cualquier déficit de este factor, si es muy intenso, puede dar problemas hemorrágicos. Son todos de herencia no menos el 8 y el 9, son de herencia autosómica dominante, no van ligada al sexo, por lo que también lo puede padecer una mujer, ¿vale? Y luego todas las trombocitopatías, que son enfermedades más raras. Trombocitopatía quiere decir que las plaquetas funcionan mal, ¿vale? Y las personas que tienen pues, algún tipo de trombocitopatía pues pueden sangrar. Y el tratamiento de estas patologías pues son pues, lo mismo, es concentrados de factores, o plasma, o encefibrin, o desmopresina, o incluso transfusión de plaquetas. ¿Vale? Entonces, ahora ya vamos a entrar en el bloque de lo que es más concreto de la mujer. Entonces, el sangrado menstrual, la menstruación, es donde la mujer, cuando aparece, pues puede tener problemas hemorrágicos si tiene una coagulopatía más o menos severa. Por si no lo sabéis, la menstruación se empieza en el día, el ciclo menstrual empieza en el día 0. ¿Vale? En el día 0 lo que pasa es que se cae todo el endometrio que ha ido proliferando en las diferentes etapas del ciclo, ¿vale? Y si no hay un óvulo fecundado que se instale en la capa de endometrio, el endometrio se cae y vuelve a empezar el día 0, ¿vale? ¿Y cuál es el flujo normal? ¿Cuál es el flujo que se espera que se considera normal? Pues porque yo cuando pregunto a las pacientes ¿cómo es tu menstruación? El 99% me dicen normal, ¿vale? Entonces, ya porque es normal. Entonces, el flujo normal se considera que es entre 40 y 50 mililitros por ciclo, ¿vale? Y se define el sangrado menstrual abundante como un sangrado que ocurre de forma regular en el tiempo, o sea, que ocurre cada 28 días, pero que se sangra mucho o este sangrado dura muchos días, ¿vale? En general se considera que es cuando superan los 80 mililitros por cada ciclo. ¿Y cómo se mide esto? Porque es muy subjetivo. Hay una forma, un método exacto que se llama dosificación de la hematina, que la hematina es un derivado de la hemoglobina, de los glóbulos rojos. Entonces, pero esto solamente se usa para ensayos clínicos y cosas muy, muy concretas. En la práctica clínica diaria esto es imposible, ¿vale? Entonces, se hacen como métodos más indirectos, que es, pues, si hay mucho coágulo, si son muy grandes, si hay anemia o ferropenia, si una mujer tiene anemia o le falta hierro, es que por algún sitio sé que sangra más de lo normal y su cuerpo no es capaz de compensar esta pérdida de sangre. O porque hace un uso aumentado de compresas o tampones, de cualquier material higiénico. Y luego hay unas escalas bueno, que es la gráfica de Higham o el payback score, que aparecieron en los años 90, que intentan un poco objetivar este sangrado, ¿vale? Entonces, esta es el payback score, que lo que se trata es de ir poniendo palitos cada día del ciclo. Y pues yo gasto 3 compresas de estas y aquí gasto 2 y aquí ya solo gasto 1, ¿vale? Esto da una puntuación, un score, y si el score es más de 100, se considera que hay un sangrado abundante, ¿vale? O excesivo. Ahora, en la época de la tecnología, pues hay 20.000 aplicaciones que puedes ir apuntando cómo es tu flujo, si es abundante, ¿vale? Y lo que nos ha facilitado un poquito la medida, es la copa menstrual, que lo usan pues mucha gente joven. Yo creo que la gente joven cada vez lo están usando más, que esto ya yo me he encontrado que vienen y te dicen, yo me cambio la copa mediana 2 veces al día y está llena por la mitad. Pues ya sabes que son 30 mililitros, ¿vale? No hace falta más cosa. Bueno, ¿y de qué número estamos hablando? ¿Cuántas mujeres tienen sangrado menstrual abundante? Bueno, pues de toda la población general, tengan o no tengan hemofilia, tengan o no tengan coagulopatías, se considera que entre el 10 y el 35% tienen un sangrado menstrual abundante, pero que solamente un 20% tendrán un trastorno hemorrágico por debajo. Si lo miramos al revés, preguntamos, de todas las mujeres que se conoce que tienen una coagulopatía porque tienen una enfermedad de von Willebrand, porque son portadoras de hemofilia, ¿cuántas de ellas tienen o pueden tener trastornos hemorrágicos? Pues nos podemos ir hasta el 90% según qué estudio vamos mirando. Un paréntesis es la menarquia. ¿Vale? La menarquia es la primera menstruación que aparece en la niña, ¿vale? Que aparece sobre los 12 años, una cosa así. En este periodo de la menarquia, en estas primeras menstruaciones, son muy irregulares. Pueden aparecer cada 20 días, cada 40 días. ¿Qué pasa? Que a veces es difícil preguntar por el sangrado, porque muchas pueden o sobre o infraestimar el sangrado, ¿vale? También depende con quién se comparen. Si se comparan con su prima, que también es portadora de hemofilia y su prima sangra mucho y ella sangra igual que su prima, pues ella dirá que sangra normal, porque es lo que está viendo con quién se compara, ¿vale? Entonces, y también a veces la percepción es inconsistente, porque como los ciclos son muy irregulares, también un mes sangra más, un mes sangra menos, y quien tenga algún hijo adolescente sabrá que nunca se acuerdan de nada y solo se acuerdan de lo que les interesa, ¿vale? Entonces, pero bueno, en su mayoría el sangrado menstrual es un sangrado funcional, o porque tengas una coagulopatía o por desarreglos hormonales, ¿vale? ¿Qué consecuencias tiene el sangrado menstrual abundante? Bueno, sin dramatizar mucho, ¿vale? Pues el sangrado te puede limitar tus actividades de vida diaria y te reduce tu calidad de vida, pues si tienes dolor encima, pues peor, ¿vale? Pues tienes que tomar medicación, pues en las primeras menstruaciones, en la menarquia, los primeros años, pues te puedes sentir mal, no vas al cole, no vas a trabajar, puedes tener anemia y en casos muy extremos pues puedes hasta necesitar hospitalización. Bueno, y también para volver a poner un poquito de ciencia, pues mira, este es un estudio en el que mira que las mujeres con sangrado menstrual abundante, ¿qué alteración, qué coagulopatía tienen? Pues por lógica, porque es la coagulopatía más frecuente, la mayoría de mujeres pues tendrán una enfermedad de von Willebrand, seguido por las portadoras de hemofília, ¿vale? Y luego pues todos los demás déficits que hay. Y aquí, ¿y qué valor? Si os acordáis, el valor que se considera por debajo del cual se tiene hemofilia es el 40%, ¿vale? Pero aquí en este estudio, que es el mismo que os he enseñado antes, pues se ve que ya por debajo del 60%, que en teoría no se consideraría hemofilia, pues hay un riesgo mayor de tener anemia, necesitar hierro, ¿vale? O sea, uno sería las mujeres que no tienen hemofilia o que tienen valor por encima del 60%, y hay más restricciones en la vida diaria por culpa de este sangrado. ¿Y qué tratamiento podemos hacer cuando pasa esto? Pues bueno, hay dos bloques de tratamiento. Uno es el tratamiento hormonal, que yo ahí no digo nada porque se encargan los ginecólogos, y luego están los tratamientos no hormonales, que de estos pues un poco sí que nos tenemos que encargar nosotros, que es o dar antifibrinolyíticos o, aunque os sorprenda, el ibuprofeno, y yo doy fe, ¿vale?, reduce el volumen del flujo porque inhibe las prostaglandinas, que es una sustancia que hay allí en el endometrio que hace que se contraiga y que entonces se sangre menos. Y luego pues puedes dar tratamientos más específicos, puedes dar desmopresina, o incluso mujeres que tengan niveles de factor 8 pues muy bajitos o otros déficits más severos de otros factores, pues puedes dar concentradores de factores para disminuir ese sangrado. ¿Vale? Entonces, ahora voy a pasar a la siguiente parte, que sería un poco más la centrada en lo que es hablar un poquito de lo que es el diagnóstico prenatal y un poquito de todos los cuidados que hay que tener de cara al embarazo. Entonces, primero hablaré, dos cosas de lo que es la parte más previa al embarazo en sí, a la parte de concepción y el diagnóstico prenatal. Bueno, y primero de todo, os quería enseñar esto, que esto es la información previa que dice la Federación Mundial de Hemofilia que tiene que saber toda mujer, ¿vale? Entonces, lo dice la Federación Mundial de Hemofilia para todos los países. Entonces, una mujer tiene que saber, que lo sabéis seguro, la probabilidad de transmitir la hemofilia al bebé, ¿vale? Las consecuencias de heredar la hemofilia, tanto si es un niño como si es una niña. La forma en que se controla la hemofilia, qué atención tienes en tu zona, cuál es el costo. Y luego la mujer también tiene que saber qué atención debe recibir durante el embarazo, el parto y el alumbramiento, ¿vale? Y luego también qué opciones tiene para la concepción y el diagnóstico prenatal, ¿vale? Entonces, respecto al diagnóstico prenatal y la concepción, bueno, pues puede ser que haya un embarazo, ¿vale? Pues ¿qué hay que hacer? Pues hay que hacer un diagnóstico prenatal. ¿Hay que hacerlo o no hay que hacerlo? Hay lugares que, no aquí, pero que, bueno, se puede hacer el diagnóstico prenatal por dos motivos, porque si el bebé tiene una hemofilia y yo querré interrumpir este embarazo, que esto es una cosa personal, que ahí influyen muchas variables, o porque yo quiero saber si este bebé tiene hemofilia o no, porque de cara al parto o a las maniobras que se harán, pues pueden un poco variar si es hemofilia o no. Entonces, hay dos maneras tres, de hacer un diagnóstico de portador, ¿no?, del bebé. Entonces, uno es la biopsia de corión, que es lo que es esto de aquí, se biopsia las vellosidades coriónicas, que es una membrana que hay en una parte de la placenta. Entonces, por ecografía se pincha el abdomen o a través de un catéter por la vagina y se toma una muestra de estas vellosidades que hay en la placenta, que tienen la misma información genética que tiene el bebé, ¿vale? Y se hace un estudio genético y se ve si el niño tiene el gen de hemofilia o no. Esto se puede hacer en la semana 12, 14, ya se puede hacer. Y luego lo que también se puede hacer es una amniocentesis, ¿vale? La amniocentesis lo que se hace es que se pincha la pared abdominal de la madre y se llega al líquido amniótico, que es el líquido en el que está el niño flotando, y se saca muestra. Se separan las células del feto y se mira si tiene hemofilia o no. Y esto se hace un poquito más tarde, entre la semana 14, la 20, una cosa así, ¿vale? El diagnóstico más precoz sería la biopsia de las coriónica. Y luego también simplemente puedes saber el sexo del bebé, si es un niño o una niña, ¿vale? Entonces, esto se puede hacer pues, por ecografía, ¿vale? O también desde la semana 8 de gestación se pueden aislar por el plasma de la madre, porque en el plasma de la madre hay algo de material genética del bebé y se puede saber si es un niño o una niña. Pero ¿qué puede pasar también? Que se quiera un diagnóstico genético preimplantacional, ¿vale? Entonces, ¿esto cómo funciona? Esto es una fecundación in vitro, ¿vale? ¿Qué quiere decir? Que se saca de la madre óvulos y se fecundan en el laboratorio con el esperma del padre, ¿vale? Entonces, eso es lo que se llama una fecundación in vitro. Esto se deja crecer, luego se toma una muestra de estos embriones, se hace un análisis genético y entonces se sabe qué embriones tienen hemofilia o no, sean niños o sean niños. Otra opción que se puede optar es una fecundación in vitro con óvulos de donante, ¿vale? O al revés, hacer una selección de esperma. Bueno, también la selección de esperma también se puede hacer únicamente, se puede seleccionar del esperma del hombre los que son del sexo, por ejemplo, femenino, ¿vale? Y hacer una fecundación con los espermas seleccionados del sexo femenino. Vale, bueno, y ahora ya entraríamos en el embarazo. En el embarazo, el cuerpo es muy sano, ¿vale? Muy sano, muy sabio, ¿vale? Sano a veces no. Es muy sabio, a veces sí, a veces no. Y en el embarazo lo que pasa es que todas las proteínas que ayudan a coagular, ¿vale?, aumentan. ¿Y por qué aumentan? Porque preparan a la mujer que en el momento del parto pues no sangre, ¿vale? Únicamente las plaquetas, que son células que sirven para coagular, pues pueden disminuir durante el embarazo, pero por un problema que se diluyen. Hay más líquido en la mujer y entonces están como más diluidas, ¿vale? Y esto lo podéis ver aquí. Este es un estudio en el que se ve que las mujeres portadoras de hemofilia, con von Willebrand o otras coagulopatías, pues sangran con la menstruación, ¿vale? Tienen sangrados entre las reglas, pero no sangran durante el embarazo, ¿vale? Las mujeres con enfermedad de von Willebrand y portadoras de hemofilia no sangran más en el momento del parto y del embarazo que las mujeres controles, que serían en las que no tienen hemofilia, ¿vale? Siempre formas que no sean graves. Las formas graves, por ejemplo, de enfermedad de von Willebrand, aunque durante el embarazo el von Willebrand sube, si tú tienes un von Willebrand muy severo, pues no es capaz de subir, ¿no? En todas las mujeres el factor von Willebrand sube a unos niveles más seguros, ¿vale? Entonces, quien sí que puede sangrar durante el embarazo son otros defectos, porque, por ejemplo, las plaquetas o problemas relacionados con las plaquetas durante el embarazo no aumentan, ¿vale? Pero sí, si bien no se sangra durante el embarazo, pero sí que se puede sangrar durante el posparto, ¿vale? Y esto hay que saberlo respecto a los controles. ¿Veis? Los controles están aquí y aquí pues vuelve a subir las mujeres que sangran con otros trastornos, enfermedad de von Willebrand o portadoras de hemofilia. Mira, os enseño esta gráfica, muy rápido, no de esto, es para que veáis que, porque se ve, bueno, yo quiero que se vea muy bien, es una enfermedad de von Willebrand que los niveles de factor von Willebrand durante el embarazo suben, y cuando es el momento del parto, rápidamente baja, ¿vale? Entonces, ¿esto qué quiere decir? ¿Esto por qué os lo enseño? Porque, por lo que he dicho antes, que se puede sangrar más en el posparto que no en lo que es todo el proceso del embarazo. ¿Vale? ¿Y qué hay que hacer? ¿Vale? Si te quedas embarazada, ¿y qué tienes que hacer? Bueno, pues primero, lo recomendable es tener siempre unos niveles de factor, de von Willebrand, de factor 8, de lo que sea, antes de quedarte embarazada para ver de dónde partimos. Habría que hacer una determinación cuando uno sabe que está embarazado, ¿vale? En el tercer trimestre, para ver cuánto ha subido este factor, y siempre antes de cada maniobra invasiva, ¿vale? Y en general, pues uno se tiene que conocer porque hay personas que sangran más y personas que sangran menos, ¿vale? ¿Y el tratamiento? Pues el tratamiento durante el embarazo es poco frecuente el sangrado, no hay que hacer nada. Únicamente cuando haya que hacer alguna maniobra invasiva hay que asegurarse que se tenga unos niveles de factor en general por encima del 50%, ¿vale? El problema viene un poco más en el momento del trabajo del parto o cuando ya que ya sale el niño, ¿vale? Entonces, bueno, la cesárea únicamente, el criterio de hacer cesárea o no es por el criterio del ginecólogo, del obstetra, ¿vale? Y se recomienda hacer, pues siempre se recomendará hacer un parto poco traumático y no utilizar forceps y estas cosas, ¿vale? Y donde hay que tener un poco más de cuidado es en el posparto, por lo que os he dicho antes, ¿vale? Hay que tener unos niveles óptimos de factor hasta el 4.º día si es un parto vaginal o hasta el 5.º día un poco más si es un parto con cesárea. Habría que hacer unos niveles de hemoglobina a la alta, ¿vale? Y hay que explicar bien que hasta 2 semanas después del parto o incluso un poco más puede haber algún problema de sangrado, ¿vale? Y esto hay que saberlo. Y ya está. Muchas gracias por vuestra atención.
Bueno, em sentiu? Val. Bueno, la veritat és que estem molt contents perquè la sala està plena. Això vol dir que ens està interessant molt totes les ponències i a més hem tingut un suport, jo crec, que de part del govern i del Departament de Salut avui molt important. Primer la Meritxell Budó, que ja hem dit que preferim amb ella veure-la més que com del departament, com la patrona de la Fundació, i que això ens fa que està més a prop. Però sí que tenim aquí la presència del conseller Argimon. Tenia un dia molt complicat, de fet gairebé fins ahir o abans d'ahir no ens va confirmar que podia passar una estona adreçant-nos a unes paraules. Per nosaltres, conseller, és molt important. Fem una feina de pica-pedra, ja ho saps, i per la soci el suport vostre és absolutament imprescindible. Si ens vols pujar d'alguna cosa, gràcies, conseller.
Bon dia a tothom, bon dia a totes i a tots. Moltes gràcies, Oti, patrona, patró, alcalde Trias i consellera Budó. És veritat, avui és un dia, no avui, sinó des de ja fa unes quantes setmanes, i especialment els dissabtes i els caps de setmana, divendres, dissabte, doncs tornem a recuperar una normalitat que per la pandèmia havíem perdut, que tornem a retrobar-nos en jornades, en simpòsiums, en seminaris, en congressos, com els d'avui, i això d'entrada ja és una bona notícia, ja és important. I el fet aquest de poder retrobar-se, i més en una jornada com la d'avui, que ja és la número 14, això vol dir que és una jornada molt consolidada. I aquestes jornades serveixen per intercanviar informació, experiència, coneixement, necessitats, i aquest element també és molt important poder-lo fer cara a cara. Certament, la pandèmia ens ha portat molt de streaming, molt de Zoom, molt de plasma entremig. Les coses també es poden fer, també des d'aquest punt de vista aconseguim arribar a més gent, és cert, però hi ha aquest element humà, aquest element del cara a cara, quan parlem d'intercanviar el que deia, experiència, informació, necessitats, coneixements, que això és molt difícil de suplir-ho, de suplir el cara a cara. I per tant, el fet que ens puguem trobar és molt i molt important. L'altre punt també és que són jornades i cada cop més, i crec que això és el bo, on les associacions de pacients, familiars, amb professionals, treballeu plegats i conjuntament, i són jornades d'actualització on hi participeu tots els actors davant d'una malaltia i davant d'una decisió. La primera perquè els pacients sou els que millor coneixeu la vostra malaltia i sou els que tindreu que prendre les decisions sobre la vostra malaltia. Decisions que hauran de ser compartides, això sí, compartides amb les persones que us cuiden, que us acompanyen i que, d'alguna manera, us donaran també la informació necessària, informació que sigui veraç, que sigui contrastada, que estigui basada en l'evidència científica, per poder prendre, com deia, aquesta decisió compartida. Decisió que finalment serà vostra, fent ús de l'autonomia que teniu, de l'autonomia que teniu personal davant de la vostra malaltia, i perquè vosaltres sou les persones que coneixeu les vostres voluntats i les vostres preferències. Per tant, congressos on en l'actualització barregem els diferents actors i participem els diferents actors, pacients, famílies, associacions i professionals, crec que són molt i molt benvingudes. També crec que he pogut revisar el programa i ara em deien el doctor Trias i la senyora Meritxell Gondó m'explicaven que la jornada ha estat molt bé, m'explicaven també la conferència del senyor Brian Mahoney i jo tindré l'oportunitat de poder també escoltar el professor Michael Macris i per tant també m'han dit que totes les ponències, que totes les intervencions han estat molt bé i que ha estat molt interessant. Jo només un cop més felicitar-vos. Les tasques que feu a les associacions són importantíssimes. El treball conjunt, repeteixo, d'associacions, pacients, familiars, les associacions i l'administració és la manera d'avançar, conjuntament també amb la informació que ens pot donar i el coneixement que ens poden donar la societat científica. És la manera d'avançar, tots plegats, per un sistema sanitari millor, més equitatiu, més just i que, d'alguna manera, millori la qualitat de vida i millori la salut de la ciutadania. Moltíssimes gràcies per haver-me convidat i que acabi el que queda de la jornada molt bé. Moltíssimes gràcies.
Moltes gràcies, conseller Limón, per les seves paraules. Ara continuem i convidaria el doctor Macris perquè vingués a presentar la primera ponència de la segona part, amb la que ens parlarà sobre el futur de les unitats de hemofília després de la innovació de les noves teràpies que ha anunciat. Doctor Macris, és la seva paraula.
Thank you. I'm not sure whether I'm going to be talking what you said. This presentation is, when I was going to give the first presentation, Otti said to me, can you, at the end of your presentation, explain whether we're still going to need hemophilia centers in the future? And I said to Otti, well, I could do a couple of slides, but it may be better if I explain why I think we will need hemophilia centers in the future. So this is the question that Otti asked me. So will we need hemophilia centers in the future? So what's my answer? Well, my answer is, yes, we will, but they will change. They will not be the same way as you're seeing them today. And like I explained to you in my first presentation, if you have hemophilia these days, I think everything around you centers around bleeds, in relation to hemophilia. But I personally believe that we are in the era where if you have hemophilia, you can live a life without bleeds. You could go as far as Brian went and have gene therapy with no bleeds, but the current therapies should be good enough to lead you to a life without bleeds. So, this is a very typical patient, not just in Barcelona, everywhere in the world. So, why do I need to come to the hemophilia center? I have severe hemophilia, okay? It's a typical person. And people ask me this as well, as not just in your centers. So, my treatment is gene therapy, Hemlibra, factor 8 or factor 9. And it may not be entirely this way in Barcelona, but in the UK, what we do, we deliver the factor 8 of all the treatments to the patient's home. So they don't have any interaction with to come to the hemophilia center to get the treatment. And I'm not having any bleeds. So I have no bleeds. I'm getting all my treatment at home. What does the center have to offer me? Why should I bother to go to the center? Well, I'll give you an answer in two ways. The first one, I don't think it will happen in Barcelona. I don't think this will happen because, as you heard from the minister, you have their backing, and I cannot imagine a healthcare system like in Spain or in Europe will allow this to happen. But this is what's happened in the US and is happening in the US. So in the US, it's based on insurance. So if you have a hemophilia, you have insurance, you go to the hospital gets money. So what happened in the US, the hemophilia centers need the patients, need the patients to be registered and to attend to get money. So if you have no patients attending the hemophilia center in the US, the hospitals will say, it's not economical for us to have a hemophilia center, and they close them. And this happens in the US. So this is the US example. Patients in the US can choose where they get followed up. They can choose whether they go to the center or not. And in the US, the insurance companies, if the patient tells them, I don't want to go to my follow-up appointment, they say, brilliant, we don't have to pay the hospital, we make more money. So the number of patients attending the hospitals as hemophilia care started getting better went down and down. So the hospitals then question whether it's viable to have a hemophilia center. And to have a hemophilia center is not going and seeing a doctor. You have to have doctors with expertise to cover every day of the week. They have to be there. And you need nurses, and you need physios, you need pharmacists, you need psychologists. So it's the whole infrastructure. So the US healthcare system, as you know, is broken. And it's broken for hemophilia probably even more than it is for the general. So I don't think this will be allowed to happen in Europe. So the reason for that is that in Europe we don't have really many, if any, pure insurance-based systems. We have universal healthcare, and that's the best thing, any civilized country can have, as a universal healthcare system. However, hemophilia centers have to realize the world is changing, treatments are changing, and they have to change. And if they don't change, the world around them will change, and they will become redundant. One example is, at least in our country, I know it hasn't not quite the same way in Spain, most centers in Europe probably, certainly in the UK, they're now hemophilia and thrombosis center. As a doctor, I have expertise in treating bleeding due to excessive bleeding in hemophilia, but also I have expertise in the opposite of thrombosis. So you can imagine our patient population is much bigger, and we can offer a better service if we can cover both. And as you saw in my original lecture, thrombosis is a major and expanding issue. So you're going to get, and we can get the interactions between the two. So this is what our workload is in my center. So it's completely different from 1992. If you ask me what was our workload in 1992, it was mostly severe hemophilia. We had to admit people, all the time with HIV, with hepatitis, with bleeds, but all that has changed. And it's unimaginable to a doctor or a patient working in 1992 to know where we are today. So 2/3 of our workload today is thrombosis. And about 10% is severe hemophilia. It's difficult for you if you have severe hemophilia to believe that, but the hemophilia centers, most of our workload is managing patients with mild bleeding disorders because there's many more of them. And if they come to hospital to have surgery, we have to look after them. And they're not used to treatment like yourselves. So you heard I come from Sheffield, and probably you don't know where Sheffield is, but I'll show you. People in the, if you ask anybody in London, which is there, to tell you where is Sheffield, they will tell you that Sheffield's it's in the north, it's up there. But actually, Sheffield's in the middle. So I suspect it's not very different from many other countries. If you live in a capital city, your concept of where the rest of the country is and where the rest of the world is very different. And the way they think what they do is best is not always the same. Anyway, that's a separate issue. So what do we do? What does our center do for why do persons with severe hemophilia come to our center? Well, they come for our outpatient clinic reviews. And I was telling you earlier, and I didn't change the slide, what we do, if you have severe hemophilia and you're going to come for our review in our center, you may think that you're going to go there and see someone and then you walk out of the room. It's not. The 1 week before you come, we always have a multidisciplinary team meeting, and that has about 15 to 20 people. We have all of the doctors, all the nurses, psychologists, social worker, the laboratory people, and we know who's going to come for review. And we discuss every patient individually, so we know if there is any issues coming up to ask them. Then it's your review, and during that review we have a nurse, a doctor, and a physiotherapist in that consultation. The week after we've seen them, we discuss amongst the team again, who have we seen, what are the jobs left to follow up with each of them. And so don't be misled that you come for 10 minutes or 15 minutes in the room and that's it. We spend a lot of time discussing your care. So we do surgery, and obviously that is increasing because the population is getting older, we can do more things. We do some dental procedures, people who cannot have them elsewhere in the community. We provide, if the patient has had a bleed after injury, that they cannot manage at home. But this is very unusual these days, especially with severe hemophilia. So we almost never admit patients with spontaneous bleeds with severe hemophilia because the severe hemophilia patients treat themselves at home. And that's been the biggest difference. They're on prophylaxis, they're not getting the bleeds. So if you're a center that thought this is going to be the future, it's not. So why do severe hemophiliacs who do not bleed, like I asked originally, need to attend a hemophilia center? First of all, none of the current treatments cure hemophilia. Even gene therapy, I told you, it does not cure hemophilia. Hemophilia can still be transmitted. And you need the team. If you have a daughter who's a carrier and is going to carry hemophilia, you need the hemophilia center to discuss things with you. The clotting is not normal. It may appear to be normal. I told you earlier about the patient in Spain who ran into major problems because went to a hospital that didn't know anything about hemophilia. does a blood test, your clotting is normal, we'll operate. And that's what almost led to disaster. And it's not just Spain. Ask anybody else in Europe, the same things are happening. You need to be aware, if you're on certain therapies, what your clotting test will show. Coagulation tests can be misleading, and appropriate tests may not be available in all hospitals. Even in Spain, in the UK, there is one test that is available, for example, to measure factor VIII. It's fairly cheap, and it's probably available in, 30% of the UK hospitals and in all the hemophilia centers. But amazingly, the more accurate test is not available in every hemophilia center. So you may get a number, but it may not be the true number about your factor. You need to be monitored for inhibitor development. I didn't speak about this earlier. If you have had an inhibitor when you were a child and you start on Hemlibra and you have no bleeds at all, so you go on year with no bleeds at all, that inhibitor from when you were a child can come back without you knowing it, because Hemlibra works in both. So it's really important to know if your inhibitor has come back, because if you get a bleed, the treatment is not going to be factor VIII, it's going to be Nova 7. Okay? So that's an issue that is stated. And if you do get problems, you need an expert to manage you if you get a clot. In the population in general, a third of the population are going to get heart attacks or strokes. Okay? Persons with hemophilia are going to get less, because hemophilia is protective against those, but it doesn't protect you completely. You're still, if you have hemophilia, it is possible you may have a heart attack when you're over, it's not going to be when you're young, but you're over the age of 70. So what happens when you have a heart attack at the age of 70 and you go to your local hospital, if they don't have a hemophilia center? It's really, really important at that time, more than the whole of your life, to have an expert that knows what they're doing. So what do you expect from your center? And I think probably these are offered from the centers in Barcelona. Your center should be able to see you day and night, every day of the week, if you have an emergency. You should expect the person who is seeing you either to have some expertise in hemophilia or to be able to talk to someone at home who has expertise in hemophilia. You would expect them to have the concentrates in stock if you have a problem. You should expect to have a laboratory that is good enough to do all the tests. And it's not always possible, and it's not possible for you probably as a patient to know whether your center has this. And you should be able to get support for surgery 24/7. So hemophilia centers in the future. I believe we are going to have less hemophilia centers. I know this may not be very popular, me talking about this in Barcelona, but I think there will be less. But the facilities will be greater. In Norway, there is one hemophilia center. Look at the map of Norway. How far the north of Norway is from the south. It's probably in distance much longer than the bottom to top of Spain. You would expect all treatments to be delivered to the patient's home. You would expect digital appointments if the patients want them, if they don't want to come to the center. Blood samples can be taken locally and sent to the center. COVID allowed innovation. In our city, in Sheffield, when COVID came, the hospital said they didn't want patients to come to the hospital. So we organized a phlebotomy service in the community. So they put a tented city in a car park. So if we speak to a patient on the phone and need bloods, we tell them we need these bloods. We request them on the hospital computer. The patient drives to this place near the highway. No appointments. They're open 8 a.m. to 5 p.m. They go there. They tell as they drive through what their name is. They put their arm out of the window. Someone takes the blood, back in, and they drive away. You're not allowed to walk into this center, and you're not allowed to leave your car, and there is no appointments, and it's highly efficient. When they asked us, which part of COVID did we as medical professionals wanted to continue, that service is amazingly good. And I'm sure it's continuing. The nurses, doctors won't like this. I believe in the future, hemophilia care will be delivered by nurses, but the nurses will be more probably professionally trained. Our nurses have higher degrees, they have higher training, they're able to examine patients, they're able to prescribe all medications, not just factor. So in our center, I have much more faith in our nurse seeing the patient than I do for any of our junior doctors seeing them, because the junior doctors don't have the experience. So all the centers will be externally audited. We all think we do well, but how do we know? And this is coming. It's probably coming in Spain as well, but certainly it's available in Europe. It's going to come in Europe. It's available in the UK, but it's available for about 20 or 30 years, but it's going to be available in Europe as well. You're going to get people coming into your center to examine every aspect of your center. When that happens, people are scared that someone is going to come and examine our service. But after a while, we welcome it like anything. Because if someone externally comes to you, to your center, and says, you do not have a psychologist and your physiotherapy service is poor, there is nothing better for us as health professionals for an external person to tell us. Because we go to our hospital authorities and say, look, externally audited, and this is what they said. So, will we need hemophilia centers in the future? Yes, we will, but they will have to change. Thank you.
Okay, so once again, I get the tough task of following Mike. So can we have my next, my presentation, please? Okay. So Odie asked me to speak about how the Irish Hemophilia Society interacts with the government and health authorities in Ireland. So first of all, we have about 900 people with haemophilia in Ireland, and we have about 270 with severe haemophilia. Over 1,800 with von Willebrand's, 806 with rare bleeding disorders, and about 350 with inherited bleeding disorders. You can actually see we have a higher proportion of people with haemophilia B compared to A than most countries. Now, the scientists will tell you that's because of founder effects and small gene pool. I think it's because people with haemophilia B are better looking and they have more children. But I have haemophilia B, so I'm biased. So our treatment history from 1995 to 1997, we started using recombinant factor for everybody with haemophilia. In 2017, we switched all factor 9 patients to extended half-life factor because we make a national decision. And in 2018, we switched all factor 8 patients to extended half-life factor. And then 2019, we switched all inhibitor patients to Hemlibra, but then it also became an option for every patient with factor 8 deficiency now has the option of Hemlibra or extended half-life factor. 96% of the children are on prophylaxis, and 95% of the adults are on prophylaxis. And in fact, especially with factor 9, we had a couple of holdouts who didn't want to take prophylaxis, but the fact that the extended half-life meant that they could infuse once a week, once every 10 days, or once every 2 weeks. So now everybody with factor 9 deficiency is on prophylaxis. I think the background to our development and the background to our relationship with government has come from successful and persistent advocacy and from realising that if you want sustainable, better haemophilia care, you have to engage positively and constantly with the government and the health ministry. So in 1989, we had a campaign for compensation for our members affected by HIV. And quite bizarrely, in fact, our then Prime Minister, when they lost a vote in the Parliament, called a general election on that issue. And he subsequently lost seats at the election. So there was a strong political memory of haemophilia. In 1991, we did a further compensation campaign for HIV. In 1994-97, actually, we worked on compensation for hepatitis C, both with the ministry. We didn't have to campaign for that. And then from 1997 to 2001, we had discussion on terms of reference for a tribunal of inquiry into contaminated blood, into HIV and hepatitis C infection. And then the inquiry itself in 2001 had very, very massive media coverage. All of the daily newspapers covered it for the entire year. And in 2002, the inquiry reported, but crucially, there was a large section with recommendations for the future. And we put a lot of work, not just into looking at what happened in the past, but thinking about how we make a better future. And this is from the 1991 campaign. The 1989 campaign, our first booklet on AIDS and haemophilia. And this was part of the compensation campaign in 1991. That was actually the night that the compensation was announced. That's a much younger version of me with the then health minister on television. So our contaminated blood inquiry in 2002, we used that very effectively to set future direction. I think it was very cathartic for our members. They got a government apology, they got compensation, but they also felt that their story was heard, understood by the public, they'd been listened to, and they really have moved on in a very positive manner. But I think the key thing was that we thought very clearly about the future. And given the devastation of HIV and hepatitis C and the vast number of deaths that this caused in our community, we thought, how do we make sure that in future, this doesn't happen again, that we have the best possible haemophilia care? And the answer is to be in the room, to set up structures that allow for that. So there was a statutory National Haemophilia Council established, which includes the Health Ministry, the doctors from the key haemophilia centres and the Irish Haemophilia Society. And we also established a tender board, a haemophilia product selection and monitoring advisory board. And this body advises and basically selects the products for all the haemophilia and von Willebrand and bleeding disorders patients in the country. So we have one committee that selects the treatments for the entire country. And that also includes the Health Ministry, the key doctors and the Irish Haemophilia Society. We have a national budget for replacement therapy. So not each hospital, not each region, we have a national budget. The products are selected by the committee. And we've done that very cost effectively, but also some of the savings that we've made from tender to tender have been reinvested in comprehensive care infrastructure. We have a close collaboration between the society and the individual centres, and between the centres collectively and the society. So that the council, the Haemophilia Council, has had the impact. Initially it started off and it was a little strange, but you now have 4 hospitals represented on that council, and you can stop them thinking about just their own hospital. They think nationally. Oh, I'd like an extra nurse, but you know what, the physiotherapist for this centre has to be a higher priority. The ministry love this, frankly, because the ministry get us to internally agree what the priorities are. So every hospital will always tell you, we need more doctors, we need more nurses, we need more physios. And the ministry can say to us, well, hang on now, for this year, collectively, for haemophilia for the whole country, you tell us what the number 1, number 2, and number 3 priorities are. So it actually helps the ministry as well. And the society also received the majority of our funding from the health service. So we are primarily funded through a government grant. But this also means the fact that we have the council and the product selection board mean that we have regular scheduled meetings with the key ministry officials. So we meet the officials at least 6 times per year, and the meetings take place at our office in the Irish Haemophilia Society. Obviously, the last 2 years they've been virtual, but our office has been the location for these meetings. We also offer assistance and training to new officials in the health ministry, so we will train them on blood products and haemophilia. We give them some background. We've developed contacts and a collaborative way of working. And I think the officials can become advocates for haemophilia within the system. We believe that we have a blood, tissue and cells division in our health ministry, and the more knowledgeable those officials are about haemophilia and the work we do, the more it benefits us, because they then engage with the condition and with the organisation. But we also need to understand their viewpoint and learn from them how the system works and how decision-making in the ministry works. We obviously have the contact details of the Minister's special advisors, and we use them as a preliminary channel to the Minister. So we have special advisors. Sometimes I think in Ireland their job is to keep the minister safe from his own civil servants, but they're very good conduits for communication. If we have an issue that we want to discuss with the minister politically, we will prepare a detailed memo which usually goes to the advisor in the first instance. But we also collect and use the outcomes of our work, including, and this is something that organisations don't normally do, including looking at the outcomes of previous funding that we've been granted. We try to be forceful but respectful and brief. The minister and the officials' time is limited, so we don't engage in very long discussions. We summarise and brief them in that way. But we also have a clear ask and cohesion between the society and the doctors. So the ministry are not getting mixed signals. They're not hearing from us as the patient organisation, this is the priority, and from the doctors, no, this is the priority. We have a clear consensus on the way forward. And also, you know, I provide information in other areas. I sit on the board of the Blood Transfusion Service. At the Minister's request, I chair a scoliosis co-design committee, and we also help the organisation with other NGOs, so at the Ministry's request. So we've got I think, a synergistic relationship with the Ministry in many ways. But as I said, we measure the outcomes, and that's really important. And that's something many organisations don't do. So if you go to the Ministry or the government and you look for funding for something, then how was that funding used? What were the outcomes of that? So this is the impact of our switch to extended half-life factors in Ireland. So we were able to go back the following year and say, look, this is the impact. We've seen higher trough levels, we've seen less bleeds. In fact, I presented this at the ISTH conference. We did quality of life surveys. We looked at, a significant impact that this treatment had. If you look at our tender outcomes, so we've been doing these haemophilia tenders since 2002. At the end of 2019, we audited all of our work from 2002 to 2018, and we looked at the previous system we had, which is where the transfusion service purchased, and we had several purchasing. And then we looked at the EU average prices, and we looked at where our prices, how they changed. So the difference was, compared to the previous system, we would have had to spend 175 million euros more to get the outcomes we had with the previous system. That was the amount that was saved from the health budget. And if you discount that for the real value, given the different years, that comes up at about 275 million, and we're now at well over 300 million. So basically, since 2002, we have tripled our use of haemophilia treatment. We have moved to better and safer and more effective treatments, but the budget has been essentially unchanged since 2002. And as I said, we've also included 22 million in savings from handling fees and tax on handling fees. So it's not just the cost of the factor. You're looking at things like, at one point, our transfusion service was the contract holder. They were charging a handling fee. Then there was a VAT charge on the handling fee. So all of those were also removed. And as I said, some of the savings were reinvested. And interesting comparison with Belgium, because before we changed our system, we had a very similar system to Belgium. And I love showing this slide to Cedric Hermans from Brussels. But if you look at this in terms of factor use, Ireland's in the orange and Belgium's in the yellow. Factor use was about the same in 2002, higher in Ireland. So we now have higher factor use than Belgium. And in 2002, we were spending more than Belgium, but now we're spending less than half of what Belgium spends, despite the fact that we're using not only more treatment than Belgium, but all of our patients, all of them, are on extended half-life or Hemlibra. So we're using more treatment, better treatment, at less than half the cost that Belgium is doing. And this is the kind of information and feedback, frankly, you need to give to a health ministry if you're getting funding, because we can all go in and ask for funding, and everybody goes in. Minister, I'm sure you know this, everybody goes into your office and says, if you give us this funding, it will save money in the long term. You need to be able to show the outcomes. I think we also work collaboratively with them. This was when hepatitis C, when the new hepatitis C treatments came out. This is our current Deputy Prime Minister. He was Prime Minister at the time. We got him to open a conference that we organised on hepatitis C. He then came to our office for a meeting, but we persuaded the Minister and the government to prioritise people with haemophilia for access to the new hepatitis C treatments. And the reason we were able to do that was that we were able to show again with outcomes that the previous generation of treatment which had a success rate nationally of 51%, had an 80% success rate in haemophilia because everybody stuck to the protocol and we give them a lot of help and support. So that actually prioritised access for our members to the new treatments. And then, having done that, I think we thank the Ministry publicly for the outcome because we were able to effectively eradicate hepatitis C in the haemophilia community. And again, so we made our case clearly, we provided the data and the evidence, but then we communicated the results publicly, and then we publicly thanked the Ministry for their help with this. And most NGOs don't do that. So I think there's a lesson there. It's not just, this is what we would like, this is the funding we need, but then you've got to look at this is the outcome, and then you communicate that outcome as well. This was the Minister attending our annual conference in 2018, and at the time, we were using extended half-life factor, but I did flag to him that there was a new treatment coming down the line that we specifically wanted to use in the first instance for people with inhibitors. That was emicizumab. I introduced him to some people with inhibitors at the meeting, and then we switched to emicizumab pretty quickly afterwards. And the government and the Ministry also co-funded a research project with €2 million called the Irish Personalised Approach to the Treatment of Haemophilia, and that's been a very successful programme over the last 4 years. This is World Haemophilia Day this year, so again, the message here was more just in terms of celebrating because it's 20 years since the publication of our contaminated blood inquiry report, celebrating the achievements, celebrating the improvement in haemophilia care, but also reminding a new minister that haemophilia is well organised, it's well funded, we are involved in the decision process, and please don't forget that. And in fact, the young boy and the older gentleman, they both have high titer inhibitors. It was his 66th birthday, and the 11-year-old presented him with a birthday cake, but their quality of life with inhibitors is going to be vastly different from each other. Now, the 66-year-old who has high titer inhibitors has had inhibitors since he was a child. He was getting 15 to 20 bleeds per year. When he switched to emicizumab or Hemlibra, he hasn't had a single bleed in the last 3 years. And the 11-year-old doesn't see any difference between having haemophilia with inhibitors and his younger brother who has haemophilia without inhibitors. So it's really positive. By the way, the 11-year-old then took off with the cake, and we didn't get any of the cake afterwards. This is from the Minister's press release actually for World Haemophilia Day, and he commends the work of the Society, the Haemophilia Council and the Product Selection Board and the treatment centres. But crucially, we work together with the Ministry and the centres on those bodies. We develop key working relationships with key media, and we use patrons. So the last 3 Irish presidents have been our patrons, and that's really important, because it's good for the profile of the organisation. And finally, I think haemophilia organisations need to be integrated into the decision-making nationally. You don't want integration in gene therapy, but you do want to be integrated into decision-making on haemophilia care. This is a nice example from Brazil where, they show that the increase in factor use over the years effectively led from this kind of situation for boys to this. And I think as we're coming out of COVID, and as governments are looking at health budgets, and as all of our countries have spent vast amounts of money in the last couple of years. I mean, in the UK, their limit for incremental cost per quality was £30,000. My understanding is the cost per death avoided during COVID was £500,000. And that was good spending, and the government spent a huge amount. But COVID, impacted society, it impacted the economy. It wasn't just treating a rare disease like haemophilia. So I think governments are going to be looking at the need for more acute hospital beds, more doctors, more nurses. So we have to work with them. We have to move our advocacy from transactional to transformational. We have to really work closely together on co-designing the service. And I firmly believe that if you want to work successfully with governments and with health ministries, you don't go to them with a problem, you go with a problem and a solution. But you go with a solution that also fits in with the direction of the healthcare system. Thank you very much.
Sí, ara vindrà el torn de les preguntes. Llavors, si els ponents voleu pujar aquí, doctor Macris, Brian, i el torn de preguntes serà moderat pel doctor Mateo i la doctora Benítez.
El doctor Mateo se va acomodando. Primero agradecer a la Asociación AOTI, que fue quien me escribió por la... Bueno, pues agradecer a la Asociación de Pacientes. ¿Ahora? Bueno, pues agradecer a la Asociación de Pacientes y a OTI personalmente, porque fue quien me invitó a estas jornadas a las que siempre había asistido virtualmente, porque desde que llegué a Barcelona coincidió con el inicio de la pandemia, así que un placer estar aquí. Bueno, no sé si el doctor Mateo preferimos iniciar nosotros el turno de preguntas o aprovechando que tenemos ponentes como la doctora Carrasco, el doctor Macris y el señor Brian Mahoney, si la audiencia quiere iniciar este turno de preguntes.
Bé, jo també voldria agrair a l'associació i a tots els presents. És un plaer estar aquí. Jo vaig fer la residència aquí a Sant Pau i per mi és fantàstic que estigueu tots aquí. I jo per començar, i després mentre penseu més preguntes i recordar temes, jo volia preguntar al doctor Macris. El llibre ha estat un avenç impressionant al camp de l'hemofília. Transformem el fenotip d'un pacient greu en un pacient lleu, però ens queda la dubte en les persones que fan una vida molt activa, esportiva, si això és convenient o és millor continuar amb una profilaxis més intensiva en factor 8. No sé què en pensa.
Sorry. Thank you. That is true. I mean, I don't want people to go away and I think that Hemlibra is the only answer and everybody in the world should be on Hemlibra with hemophilia A. It's not. You make a very good point. Although I told you that 80% of our patients are bleed-free, it's very interesting that most of those patients are the older ones. And the teenagers and the younger patients, they do tend to, in our experience and other people are reporting, still get bleeds. And it's probably because they're being active in sport. So, yes, they will get less bleeds, but they may still get bleeds. So the teenagers may be an issue, and there may be alternatives for them. As I mentioned, the product, the extra long half-life factor, BF001, that will be 2 years away. There are these other bispecific antibodies, but yeah, Hemlibra may not be the answer for everybody, but certainly the teenagers, they may still get bleeds.
Bueno, ¿hi ha alguna pregunta de la sala? ¿Alguna cuestión? Aquí.
Hola, bon dia. En primer lloc, donar les gràcies. Crec que avui és un dia molt important per una persona amb hemofília, per la perspectiva de futur que s'obre davant nostre. Jo estic molt emocionat personalment i per la implicació de tothom, que tothom estigueu aquí, departament, metges, associació, evidentment. Però vaig una mica a la pregunta. Pel que veiem, l'Hemlibra una mica és com la gran expectativa abans de lo que és la teràpia gènica, és la gran expectativa i el tractament que està donant més resultats. Jo puc parlar personalment també, i jo estic encantat. Però m'agradaria saber quin criteri hi ha a l'hora de recomanar Hemlibra, quants sagnats són necessaris per decidir que un pacient abandoni el tractament amb factor més convencional, el factor amb mitja vida, llarga vida, etc., i que passi a l'Hemlibra, perquè, clar, igual jo estic una mica, tinc un biaix pel fet que ha sigut tan espectacular el canvi que he patit des que faig servir l'Hemlibra. És que estic content, estic feliç, vull dir, d'una vida meravellosa i clar, m'agradaria que tothom també tingués accés a aquest tractament, si els criteris així ho indiquen. M'agradaria saber quin és el criteri.
Okay, I'll start by answering that question first. So in our country, the cost of Hemlibra is the same as the cost of prophylaxis with factor VIII. So to the healthcare system, it makes no difference whether a patient is on factor VIII or Hemlibra in terms of cost. So we explain to the patients it's a different way of managing it. And you may think, from what I said, that 100% of our patients are on Hemlibra, but they're not. We are at 45% of our patients. Of the patients that we started on, 2 have gone back to factor VIII. One of them because he was getting allergic reactions, and the other one because he said he just didn't find it as good as his factor VIII treatment. And despite the inconvenience of regular injections to the veins, he went back. So in patients with inhibitors, in fact, hemophilia A, it's transformative. It's changed their lives and changed our lives as well in managing them. In patients without inhibitors, there is a convenience issue because lots of patients have got very few bleeds. So that's all I can say. I don't know, the local team must have patience.
Well, aquí hi ha un problema que no tenim aquest avantatge que tenen ells, que és per un pacient habitual és bastant més car, per un pacient que amb una profilaxis de cada 5 o 7 dies està bé, és moltíssim més car. Això s'ha de treballar. No sé si hem de començar a pensar en un model com l'irlandès, que també ens ha explicat, i que és tan convenient pel sistema, perquè es pot rebaixar molt el preu segur. El nostre criteri és que cap pacient que estigui en profilaxis ha de tenir sangrats. Si sangra i fa bé la profilaxis, hem de canviar amb una altra alternativa que podria ser perfectament aquesta. Això és el criteri més important. Després, si hi ha problemes per l'administració intravenosa, si hi ha problemes de que, malgrat estigui bé en factor, té un consum molt elevat o es punxa moltes vegades, aleshores ja no hi ha tanta diferència i pot ser fins i tot que sigui més barat l'Hemlibra. O sigui, aquests són els criteris. També hi ha una qüestió que tots hem de saber, i segur que la sabeu tots, de sostenibilitat del sistema. Si ara de cop ens posem amb els nivells que podrien tenir ell, doncs jo no sé què pensaria el doctor Simón, que està aquí, dels hematòlegs. Bé, és això. O sigui, cap pacient ha de sangrar amb profilaxis amb factor i si aquesta no va bé, s'ha de canviar a Hemlibra. Però bé, s'ha de discutir cas per cas amb els vostres metges i aquesta situació. Oti?
Our experience is broadly similar to the UK. We have it as an option for every individual, but crucially, again, it does not cost more than factor prophylaxis. We negotiated on a national level contract for Hemlibra. So, if a doctor and parent or patient decides to switch, there's no cost implications for the system. And I think we have 75% of the children have now switched to Hemlibra, and 55% of the adults. Some of those who have not switched because they're very happy with their current treatment, they have very good venous access, they like the peaks for activities. We also have a number of younger men who are playing very serious Irish sports like Gaelic football, so you need those peaks. But crucially, it's very much an individual decision. Now, our system has always been a national procurement. So we have, we switched the whole country from standard to EHL. But this time they have a choice. So they have EHL or Hemofília. That also means, we've produced educational materials, they have discussions with the doctor, and then they look at really what the person wants in their life, what kind of activities they want, similar to some of the criteria I went through for gene therapy. So you then make an informed decision. But of course, unlike gene therapy, it is a decision you can reverse. So if you go on Hemofília and you find you're one of those individuals who don't get a good outcome, you can switch back to factor.
Sí. No va? Hola, bona tarda. Bon dia. Mira, jo volia fer una pregunta al Brian. Quines dificultats vau tenir a l'hora d'arribar al consens amb els metges i amb l'administració pel fet d'estar vosaltres presents a la presa de decisions en quant al factor que es comprava pel col·lectiu, quina implicació va tindre la indústria, que està acostumada a tenir tothom el seu tros, hi ha molta gent que hi ha molts productes i vosaltres us veu acabar amb un sol producte, segons he entès, de factor convencional i de Hemofília. Com veu arribar fins a això i quins problemes heu tingut?
So you can design a tender system. People think tenders are very inflexible, and you have, you do a tender and you look and you pick the cheapest product and you buy it. If that was the case, a 12-year-old could do the tender with an abacus. So what you look at, we look at all of the products, we look at safety, efficacy, quality, availability of supply, and we look at cost. We look at all of those under the EU Procurement Directive. And then we evaluate. We put a lot of work. We evaluate. We put out score sheets. We'd have like a 200, 250 point scoring system. We'd look at all of these in a very scientific way. The nice thing is it's not one doctor or one patient expert. We have all the key decision makers in the room, and we can bring in external people to advise if we need to, and then we reach a consensus on this. So the score sheet at the end reflects the consensus opinion of everybody in the room. Industry, companies don't like tender systems. Companies are more comfortable that everybody has a chunk of the market. They're very happy if they win the tender. They're very unhappy if they lose the tender. And frankly, I don't care. That's not our concern. If you want to win the tender, then come up with the safest, most effective treatment at a good cost. And companies will sometimes say, well, if we lose all the business, we will leave the country. They might for a year or two, but the next time there's a tender, they'll come back in. So we haven't, a system like this, where you bring together the key doctors, the patient organization and the ministry, removes the ability of the companies to divide and conquer. So they're not going into one doctor saying, oh, our product's fantastic and you should use that here. Because once we start a tender process, we can no longer communicate with them about those treatments once the process starts until it finishes. So, and again, it's been said to me, well, what about clinical freedom? What about clinical freedom if you only use one factor? Well, the UK tender picks a number of factors. You don't have to pick one. There have been occasions when we've picked two winners, okay? And we've often thought, should we do 75% to the winner and 25% to the second? But we felt, how do I then say to a parent that your child is getting the one that we scored second, whereas this child is getting the one that we scored first? So we just decided we'll go with the winning product. And so we have had great buy-in from the patient community and from the doctors, because the decision is made nationally, it's cost effective, we're able to increase and improve treatment every time we do a tender. But the patients like this because they know that we're only going to pick the safest and most effective treatments. And one of the ways they know that is that there are two people on that tender board. I have Hemophilia B, my colleague Declan has Hemophilia A. Whatever treatments we select, we had to infuse into ourselves. That's a great quality control measure.
I can follow that about our experience in the UK about the tender process. If you've never done it, you think someone else is deciding your treatment and they're choosing the cheapest. And that's understandable if you don't know how the process works or how it ended. In the UK, after the tender process, we ended up with 3 products that we could use on the tender for hemophilia A, and with 3 that we could use for hemophilia B. For the tender to work, all doctors have to agree that these all products are equal. And as doctors, it's indoctrinating to us and what we read and what the companies persuade us that some products are better than others. But once you look at them in detail, there is really no difference. But the doctors may not believe you. And the tender process only works if all the doctors agree that what the tender comes out with is what you will use. If you're going to allow to have a group of people to go and do their own, the tender process won't work. And you think it may not happen, but in the UK there are loads of maverick people that decide, I'm important, I will use this, I will do this. But everybody, all the doctors in the UK treat hemophilia agreed we will abide by the tender. And what the results were at least as good as what Brian showed, even better. And as you heard, we have no difficulty now in using the products. And you would think it would restrict us, but it didn't. It gave us the freedom for more products. And the idea to me, I'm sorry, I'm in Barcelona, I shouldn't say this, but to me, I cannot comprehend that a city like Barcelona, that you can have several tenders for hemophilia, and with the small number of centers, you don't come together and say, we will buy for Barcelona all the products, and we'll pay, you will pay less, guaranteed. That's what's been the experience of every country with a tender. I hope you follow it,
Podria fer un comentari donant-li tota la raó, però no cal, és prou clar que hi ha moltes avantatges. I la doctora Vilalta em sembla que vol parlar.
Sí. Bueno, jo volia aprofitar, ja que no només hi ha facultatiu, sinó que també hi ha la visió d'un pacient. Ara que tenim la teràpia higiènica ben a prop i ja quasi bé palpable, la pregunta és, quin pacient considero que seria l'ideal que hauríem de començar? Un pacient jove que té poca artropatia i que li podem millorar la qualitat de vida, o bé un pacient més gran i bé, si perd el factor, doncs llavors no serà tan dramàtic com amb un pacient jove.
I would say the ideal patient is one who has been well informed, who has read all the material, who has discussed this in detail with their clinician, and is ready to make a decision on that basis and understands the uncertainties. So it's the outcome he'd like to get versus the outcomes he may get. That's crucially important. Now, in terms of the age profile, I think you could make a case for really any age. So if you're talking about hemophilia A gene therapy, it probably looks like it's a vacation from factor, not a lifelong cure. So you might be getting the best part of 10 years without having to take factor. So do you want that in your 20s when you're very active and you want to travel? Do you want that in your 30s when you have maybe young children and you want to chase after them in the park? Do you want that in your 40s when you're moving up in your career and you don't want to be getting sick? Do you want that in your 50s when you have some joint damage, perhaps from previous bleeding, and you want to be able to be active without that impacting you? It depends. I would say many people would say the ideal age would be in new babies. That's not going to happen for a long time. So perhaps you could make a strong case for young men between maybe 20 and 35. But I think you could also equally make a strong case for older people with hemophilia who have suffered a lot, have had a lot of joint damage, if it can decrease that chronic pain. But the key thing to me is that it really depends on making sure they understand the process. And at the EHED meeting 2 years ago, David Page from Canada did a talk where he had gathered the views of about 15 people with hemophilia about what treatments they wanted in the future. There was one 84-year-old man, and he said, I want gene therapy. And when he was asked why, he said, I've waited longer than the others.
I wanted to make one other comment about the gene therapy, and that is the uncertainty. And we talked about the uncertainty of what levels you'll get, the uncertainty of how long it will last. But in a community like this, you have to have the uncertainty of a new treatment by a new modality. If you have a new factor VIII introduced into the market, you know we have pretty good experience about what factor VIII will do, you know, how it works. This is a completely new treatment. We didn't mention it, but during the development of the new treatments, there have been 2 cancers, one in the liver and one in the salivary gland. And they've been investigated in great detail, and by the companies and the responses, it was unrelated to the gene therapy. And so as a patient, you see that and you say, it was investigated, it's no link to cancer. So I was thinking about this, and I've been looking at all the gene therapy trials and everything in detail for 5 years, at least 10 years, and I do not understand the science behind what they've done to say it's unrelated. And I asked all my friends who are interested in gene therapy and at the meetings, and they, similar to me, they don't understand. You need very highly specific knowledge. So am I convinced it won't cause any problems in 20 years' time? Well, I think it won't, but I cannot tell you the answer to that. I can tell you the answer in 20 years' time. So anybody who goes for gene therapy has to understand this degree of uncertainty as well.
Doctor Parra.
Li volia preguntar al doctor Macris o al Brian, que sembla que tenen experiències amb el registre de pacients. Nosaltres aquí a Catalunya estem... volia preguntar al doctor Macris o al senyor Mahoney sobre els registres. Nosaltres estem aquí a Catalunya intentant posar en marxa un registre de malalts amb coagulopaties i els volia preguntar la seva experiència i quines són les virtuts de disposar d'un registre acurat dels malalts amb coagulopaties.
It's unbelievable to me that in 2022 we come to a European country with a city like Barcelona. You don't know how many patients you've got with every single specific disease, and you don't have a registry. The UK registry of all patients with all bleeding disorders was set up in 1968, and it's been followed up. And again, the tender system works because we know precisely how many patients they are, where they live, you know, and all of those. It doesn't take, you know, it just needs commitment. And it's not a big commitment to form one registry. And yes, you've got 3 hospitals looking after patients. That doesn't matter at all. You can make it code the patients, make it anonymous to go up. But as a ministry, if you want the ministry to help you, they need to know how many patients are you dealing with? And are they doubly registered? Especially in a city like Barcelona, there may be patients that are attending both. And if you're going to go and argue about them, about number of patients, you need to know how many you've got. And how can a city like Barcelona not have a single registry?
I'm not as surprised as Mike, because Sweden, which is one of the most advanced hemophilia care systems in the world, only started a registry about 10 years ago after a HTA process. So they had 3 centres with separate lists of patients. They didn't have a national registry. Look, I'm a huge fan of national registries. And in this case, for Catalan, I think one registry, it allows you to plan. I mean, governments do censuses for a reason. It allows you to plan if you know how many people with severe, mild or moderate each bleeding disorder, the age profile, the severity profile. It also, you can predict supply and demand for a tender, but really the registry is the basis for all of your collaborative work. And I know hospitals, you get these esoteric discussions about who owns data, which I've always found, frankly, bizarre. I mean, if I have a blood test and my factor level is this, who owns that data? I assume I do. But the fact is that hospitals don't want to lose the data from their patients. That's absolutely fine. You can collaborate, you can pool this data either with full data or names, or you can have, as Mike said, anonymized with unique identifiers. You can also if you're starting off, you could look at the World Bleeding Disorders Registry, which passed 10,000 patients this week, organised by WFH, and look at how to put a registry together. What we have is we have a registry where whichever centre you go to in Ireland, you're also registered at the national centre, and that centre holds the registry, and the data is shared between the 4 haemophilia centres, and they actually have an electronic patient record system that they share. So if I attend the centre in Dublin, if I go to Cork or Galway, they can actually look up my full medical record there with the electronic patient record system. But I think a registry is key to planning and to predicting supply and demand.
No sé si hay otra pregunta, si no, yo quería aprovechar. Bueno. Vale.
Us heu preguntat per què sempre amagant els interruptors dels micros? Que sempre costa molt de trobar. No, volia dir que realment hi ha una mena de registre, però és completament insuficient, que és el registre de malalties minoritàries, que és el REMIN, que és com si diguéssim l'oficial, que allí el Servei Català de Salut sap quants pacients hi ha introduïts, que no els que hi ha de veritat, amb hemofília greu, però no hi ha cap altra dada clínica, ni quin factor consumeixen, ni quan gasten, ni moltíssimes coses que són molt importants, no només per el control de la població, sinó per extreure dades científiques i respondre a preguntes que tota la societat vol. Quin pacient es beneficiaria més, jo què sé, de teràpia gènica, de totes aquestes coses que han sortit. Això és fonamental. S'ha provat històricament moltes vegades, no només aquí a Catalunya, sinó a tot l'Estat, i no hi ha cap registre a tot l'Estat. Vull dir que és un problema que excedeix les voluntats de la gent que vol tenir el registre.
Bueno, yo. Vale, hay una pregunta.
Hola. Yo quisiera preguntar, porque evidentemente de hemofilia se habla mucho, de tratamientos hemofílicos también, pero hay otras coagulopatías que en los tratamientos o se sabe poco o nos llega poco a los enfermos. ¿Ah, no? Ah, perdón. ¿Lo repito? Y entonces, pues, ni siquiera aquí, ¿no? En España hay, supongo que a nivel médico, no sé, no se tiene mucha información. Entonces, ya que están ustedes aquí, quisiera preguntar sobre los Billy Brands tipo 3 con inhibidor, si en sus países o aquí, ¿no?, hay algún tratamiento habitual o de forma más o menos como los hemofílicos, ¿no?, que es programado y tal, porque en realidad los resultados que tenemos los enfermos son iguales, artropatías, sangrados, y que no se pueden realizar según qué intervenciones, etcétera, etcétera. Y es simplemente para tener más información.
That's an interesting question, and the difficulty is to do with numbers. So you're starting with von Willebrand's disease, that we say is the commonest bleeding disorder, then you end up with type 3 von Willebrand's disease, and you have, say, I don't know, in a country like Spain, 100 patients with type 3 von Willebrand's disease, and then you end up with von Willebrand's disease with type 3 with inhibitors, and you end up probably less than 5 patients in the whole of Spain, such as yourself, with type 3 with inhibitors. There is one interesting... There is one interesting development that you may like to hear with type 3 von Willebrand's disease with inhibitors, and that's the possibility of using Hemlibra. Okay? That may sound crazy, and however, there was a young girl in the United States that was bleeding quite a lot with type 3 von Willebrand's disease and an inhibitor, and she was given Hemlibra, and she stopped bleeding completely. So that was published and as a single case report. And then some other people started treating patients with type 3 von Willebrand's disease with and without inhibitors. And so far, the data that has been presented has been very, very good. So the question is, do I think is the treatment of choice? You have to be a bit careful if you are, say, a clinician. You listen to someone that tells you a traumatic result. So I do not, as a doctor, know whether the 5 or 10 patients that have been presented at meetings is all the patients with type 3 and inhibitors that have been treated and had dramatic good results, and there is 100 that have been treated and they didn't have any results, or the other group is 0. So based on all the published data on inhibitors in type 3, the data is looking very good. And so what would I do? I'm not going to tell you what should happen in Spain, but I think if you have type 3 with an inhibitor, which bear in mind is so tiny, I think it is reasonable to make a special case to fund the treatment to see whether Hemlibra will be the answer. And you, as a ministry, may not cost them. It's actually going to be a cost saving, because the cost of treating type 3 von Willebrand's disease with an inhibitor is going to be so much more than the cost of Hemlibra. And you can come to some arrangement, give it for 3 months and see what happens. So that's my comment on that.
Estoy completamente de acuerdo. O sea, el tratamiento estándar de la enfermedad de von Willebrand tipo 3 que necesita profilaxis es tratamiento con factor, pero cuando tenemos un inhibidor es una de estas situaciones que a nadie le gustaría tener, ni al paciente ni al médico, y sí que hay datos muy esperanzadores con el Libra. Y tiene cierto sentido en realidad. Parece una cosa que dices, bueno, doy un tratamiento que hace de factor 8 y me arregla el Willebrand, pero es que el Willebrand tiene dos vertientes. Una, que el factor 8 de la enfermedad de von Willebrand no funciona y a lo mejor esta parte la arreglas con el Enlibra. Entonces es como quizás una de las posibles explicaciones, ¿no?, de por qué va bien. No sé.
Two very brief points, well, 3. There are new von Willebrand guidelines, so there is more work being done on von Willebrands, and there is a recognition internationally that von Willebrands and indeed the rare bleeding disorders have been comparatively neglected compared with hemophilia. Secondly, I think to reinforce the importance of a registry, I mean, I can tell you in Ireland we have 1,896 people with von Willebrands. Of those, 7 have type 3. So I'm not having to guess, I know from the registry. And thirdly, in terms of treating inhibitors with Hemlibra for factor VIII deficiency, certainly it was actually cost effective to the extent that it saved money. Because one of the things that used to give our payers nightmares was the unpredictability of spending on high-titer inhibitor patients who got bleeds. So they've actually found that they have saved money since they switched them to Hemlibra. So not only is it giving them a much better clinical outcome, but they're actually saving money.
Bé, bon dia. Jo volia primer de tot reiterar l'agraïment tant a l'administració per la seva presència com a tots vosaltres. Moltíssimes gràcies per venir d'altres llocs a parlar sobre la hemofília i oferir-nos aquesta trobada tan interessant. Per suposat, gràcies a l'associació. I aprofitant aquesta trobada internacional, m'agradaria preguntar, amb l'ànim també de que li pugui servir a algú d'aquesta sala, com a mi m'han servit les demés preguntes, com d'alguna manera s'encara o quina és la forma més comú que hi ha avui en dia en altres països d'afrontar un tipus d'hemofília moderada, lleu, d'un pacient que, a més, porta una vida, diguem, moguda, esportiva, que a l'any acaba necessitant, fent una mitja, 3 o 4 administracions de factor. Quina és la forma més comú i si alguna d'aquestes millores que heu comentat avui, aquest matí, estan previstes o d'alguna manera es veuen amb millors ulls per tipus de pacients. Moltíssimes gràcies.
That's more of a clinical question. I'm going to pass it back to Mike in a moment. Certainly in Ireland, if you have moderate haemophilia, but you get bleeds, you are treated as severe. So you have the option. So everybody who has moderate haemophilia who is getting bleeds has the option to look at factor or Hemlibra if they have factor 8. With mild haemophilia, I think the centres are finding that they're spending more of their time on mild haemophilia than they used to in the past, because if you take people with severe haemophilia and you give them Hemlibra or extended half-life factors, then you're basically giving them a level that might be 5% or above, with Hemlibra's 10% or above. So you're actually turning them into mild. But we have better coping skills insofar as we're used to bleeds, used to dealing with them. Certainly our centres found that people with mild haemophilia, sometimes there's a delay in them recognising the bleed. There could be a delay in coming into the centre. So what we start to do is we run specific information meetings now for people with mild haemophilia. And a lot of it's about recognising a bleed early and contacting the centre and being aware of this. But with moderate haemophilia, I think if they are bleeding regularly, then they're treated as severe.
You won't escape, because I'm going to pass the microphone to you about what you would do, because I'm sure you're facing this as well as us. So with mild haemophilia, it's more complex because you get less bleeds. I think if you're getting 4 bleeds a year, the question is it really mild or is it more on the sort of moderate aspect? With hemophilia A, it's a bit easier, because with hemophilia A, there is another product called DDAVP that can be given as an intranasal spray or injection under the skin, and it only acts for 12 to 24 hours. So for mild hemophilia A, we had a family where the children, teenagers, used to play soccer, and they used to get injuries and be injured for a significant part of the season. But actually, we gave them the treatment themselves. So after each game, if they got injured, they would treat themselves. And then we gave it before each game. And then it stopped them actually having hardly any bleeds. But that's with hemophilia A, because in mild hemophilia A, there is a treatment. It's not the same with mild hemophilia B. Mild hemophilia B, it's more complex. But I could argue, go and see your hemophilia center, discuss with them. If you're having 3 to 4 bleeds a year, and it's after injury, and you know that that injury is going to cause the bleed, maybe you should have some treatment before the injury to prevent you having the bleed in the first place. What would you do? You're both hemophilia treaters.
Sí, estamos en ello, ¿no? A ver. Sí, estamos en ello. Ya este año ya hace una actividad muy física y muy temporal y ya estamos en ello.
Bueno, de hecho, añadir que se están revisando el tratamiento de los pacientes con hemofilia moderada, sobre todo que tienen entre el 1 y el 3%, porque si a los pacientes graves queremos tenerlo entre el 3 y el 5% y la mayoría del tiempo están por encima de esos niveles y posteriormente van bajando, se da un poco la paradoja de al final los pacientes moderados, sobre todo esos que tienen nivel entre el 1 y el 3% basal, que siempre están igual, están peor controlados que los pacientes que son graves. Entonces sí que desde muchos grupos de trabajo se está planteando ya la idea que los pacientes moderados con niveles de factor entre el 1 y el 3 inicien profilaxis, sobre todo si están teniendo problemas de sangrado o si en los estudios de ecografías vemos que tienen daño articular, que quieren decir que están teniendo sangrado aunque sean subclínicos.
Creo que entre debajo del 3% lo tengo muy claro, pero claro, si tienes el 7, el 10, el 12 y tienes una actividad física muy activa, ahí es donde está ahí un poco más difícil el cómo manejarlo.
Hola. Sí? Jo? He fet alguna cosa? Se sent? Se sent? Val. Mireu, no, Sabeu què passa? Que anem una mica llargs en el temps i li havíem promès a l'amic Xavier que sortiríem amb temps perquè ha d'anar a un altre lloc i lluny. Jo només volia dir que estem molt contents, jo crec que sí, i com hem dit al principi, avui ens faltava el Miquel Rutllan, el qual hem recordat, que era absolutament difícil trobar un substitut. Ell no és substitut de ningú, perquè el Xavier Trias, amb nosaltres, sempre ha estat present. És la persona, com pocs consellers jo crec, que fins i tot han anat a cases de domicilis de malalts en moments de necessitat. Ens hem barallat molt, però ens hem estimat molt, perquè ell sabia que ho fèiem des de l'honestedat. Jo crec que fins i tot quan vam posar una denúncia el vaig anar a avisar, mira si sou bona. Vaig dir, ho sento, és que t'estimo però et toca. Però sempre això ens ha portat a que ell també sap que si ens ha dit això no, Xavier Trias és molt bo i va dient sí, sí, ara quan una cosa la veu clara també diu posa't com vulguis, Oti, que això no serà. També li agraïm, perquè que les persones siguin clares és molt important. El Xavier Trias, a part d'estar amb nosaltres perquè va estar molts anys de conseller de presidència, va ser la persona que va impulsar la Fundació d'Hemofília, va ser el que ens va donar els primers recursos per constituir-la i va nomenar el primer patronat on hi havia el Miquel Rutllan, amb nosaltres, amb l'Adolfo, que avui no ha pogut venir, amb l'Edu, que no sé on ha anat, tan nerviós aquest noi, però bueno, avui tanquem el cercle. Vull dir, vam dir, Xavier Trias, et toca ara ser patró d'aquella fundació que tu vas crear. I va dir, és que tinc molta feina. I vaig dir, m'és igual, aquesta l'has de fer. O sigui, l'Associació d'Hemofília i la Fundació d'Hemofília t'ha de tenir al costat. Perquè allà tenim una foto a l'associació, que tots l'heu vist, que també sabeu que no és per ell, estem allà pel Miguel Ángel. No sé si està la Vicenta per aquí. Però bueno, estem pel Miguel Ángel i per ell. Sense més, vull dir-vos que al Departament de Salut ens sentim recolzats perquè sabem que és un dissabte i que esteu aquí i que a més he estat més temps fins i tot del que teníem previst. Nosaltres, com som les socis, som així, seguirem després amb les preguntes. Nosaltres no tenim temps. Estem aquí fins que faci falta les preguntes que vulguin, però volem tenir la consideració amb vosaltres. No sé, Xavier Trias, si ens vols...
Bon dia a totes i a tots. Ja sabeu que quan l'Oti diu que has de fer una cosa, o la fas o estàs mort. I per tant diu, escolta, m'has de formar part del patronat, doncs ja estic en el patronat, content d'estar en el patronat. Jo crec que el primer que hem de fer avui és donar-li les gràcies a l'honorable conseller d'estar aquí amb nosaltres, però no està només per dir unes paraules, sinó quedar-se i escoltar totes aquestes intervencions que jo crec que són molt interessants. Jo crec que avui, per 14a vegada, fem aquestes jornades d'actualització. Feia 3 anys que no podíem fer-les presencialment i actualment avui és el dia que ho fem presencialment. Això dona força a tothom, no només a l'associació, sinó que jo crec que dona força als professionals i també hauria de donar, jo crec que dona força a l'administració pública. És a dir, el resultat de tot això és d'una gran col·laboració. Avui, tant Michael Marcris com el Brian O'Mahony ens han fet unes explicacions que és un luxe. Jo els vull donar les gràcies molt especialment de que hagin vingut i que a més ho hagin fet presencialment, perquè escoltar-los jo crec que crea una situació especial. Vostès saben, jo he sigut conseller de Sanitat durant temps, amb l'Associació d'Hemofília hem viscut des del naixement fins passar-ho molt malament, perquè vam viure uns anys molt, però molt difícils, i la veritat és que tenir conferències i persones que lluiten uns professionalment amb la recerca i tirant endavant els nous tractaments, i uns altres amb la defensa dels interessos de la gent i dels associats, jo crec que és molt important. I veure que hi ha diferents maneres de col·laborar és molt important. I ser capaços d'entendre que ningú pararà els avenços científics, ningú els pararà. Els avenços científics creixeran i els propers anys seran importantíssims, 5, 10 anys. I nosaltres, des de l'administració o des de la societat civil, haurem de ser capaços de donar respostes. No és una posició diferent la que ha de tenir la societat civil de la que ha de tenir l'administració. L'administració està al servei de la societat civil. Nosaltres tenim un sistema sanitari que és un sistema sanitari molt equitatiu, però és un sistema sanitari que hem de preservar de totes. I això vol dir ser capaços de, entre tots, buscar les millors eines en tot moment. Aquí s'han explicat coses que poden sorprendre, que resulta que té el mateix cost fer-ho d'una manera que d'una altra. Catalunya té un problema, no ens enganyem. Catalunya té un problema, el conseller ho sap bé, que no tenim totes les eines. Nosaltres no manem sobre la prestació farmacèutica. No manem sobre la prestació farmacèutica. Qui posa les tarifes, qui autoritza, no som nosaltres. Però això també ens ha d'obligar a buscar aquelles col·laboracions i aquells mètodes que facin que les coses avancin. En situacions difícils, i l'OTI n'és conscient, hem aconseguit col·laboracions també del govern central, col·laboracions que en ocasions semblaven impossibles i que han sigut possibles. Bé, jo els agraeixo molt les intervencions d'avui. Ens han fet pensar, a mi m'han fet pensar molt, i hem de ser capaços de trobar aquesta col·laboració professionals, sabent que els professionals no són només metges, sinó que aquí s'ha apuntat una línia molt clara de la importància de la infermeria, que jo crec que és evident, de futur, de professionals, de la societat civil, que són les entitats, l'Associació Catalana de Hemofília i l'administració pública. Jo crec que estem tots en el mateix vaixell i és molt important tirar-ho endavant pel bé de la gent que viu en aquest país. Gràcies.
Sí? Bé, continuem fins que l'OTI ens torni a dir que ja s'ha acabat. Abans que trobi l'interruptor del micro, volia dir només a la persona que ha parlat abans de les malalties rares, que és veritat que estan molt poc desenvolupades, pel que han dit a l'exposició, perquè hi ha un motor molt important de la innovació que ve de la indústria farmacèutica. I la indústria farmacèutica treballa, entre altres coses, i moltes vegades és la principal, per fer caixa. Aleshores, en el cas de la teràpia gènica, sí que és veritat que ens han aportat la tecnologia per poder-la fer amb les malalties que són més freqüents. L'hemofília B perquè va molt bé, la teràpia gènica, molt millor que l'hemofília A, encara que hi ha menys, i l'hemofília A perquè hi ha més. Aquesta tecnologia es quedarà i segurament el que deia el doctor Macris a la seva exposició és que s'haurà d'abordar d'una manera global perquè centre per centre o país per país igual és impossible fer teràpia gènica amb malalties d'aquestes rares, sempre i quan es pugui fer. Per exemple, una deficiència greu de factor 7, el gen del factor 7 és molt petit i segur que es podrà ficar dintre del virus, però el del von Willebrand molt probablement no. Aleshores, s'haurà d'anar avançant en totes aquestes, però és molt esperançador, ha dit un escenari de 5 anys. que venint aquí a la península seran 7, 8 o 9, però està a l'horitzó, que és el més important.
Hola, ara se m'escolta? Estic una mica fònica. Jo volia preguntar al doctor Mateo, que és el doctor del meu fill. El meu fill té hemofília severa i jo vull saber quan arribarà el tractament aquest perquè el meu fill faci una vida normal. Per exemple, jo tinc artritis reumatoide, m'han donat un fàrmac, que ara estic fent una vida normal i corrent i canvia la vida. I vull que al meu fill també li canvi la vida. I vull saber quan a Sant Pau arribarà aquesta...
No, bueno, si te refereixes en el llibre, ho està rebent ja persones, però és això que te deia, que s'ha de valorar d'una manera individual en funció de l'activitat física que faci, perquè si fa molta activitat física és més convenient fer tractament amb factor per aprofitar el pic de normalització que fa quan tingui l'activitat, i si no fa gaire activitat o és més sedentari o quan sigui, es pot valorar el canvi perquè això el transformes en un hemofílic lleu. Que amb una hemofília lleu es pot fer vida normal, però clar, si jugues a futbol, si fas esports de contacte és complicat. És una cosa que s'haurà de veure en funció del perfil clínic, de les hemorràgies que tingui i de que si, bueno, és que no em puc punxar perquè no hi ha vies, doncs serà una altra opció. Vull dir, això s'ha de mirar de manera individualitzada i això val per tothom. Però el tenim, a Sant Pau està el tractament.
També li volia preguntar a la doctora Carrasco, que ha parlat de les dones portadores. Jo soc portadora, la meva filla també és portadora. I jo no sabia que es tenia que fer el test, que es de saber quin grau tens de coagulació. Jo, per exemple, m'han operat de petita, ningú sabia que jo era portadora, he tingut hemorràgies, en les parts no. Però jo vull saber si li tinc que fer el test a la meva filla.
Sí, tu tindries que fer tu i la teva filla. Clar, perquè tu al part normalment no sol sangrar tant com en una intervenció, per ho que he explicat abans, que clar, amb el part, com el factor puja, no sangres. Però en una intervenció no hi ha el canvi aquest d'hormones que hi ha en tot l'embaràs que fa que el factor pugi. Llavors, clar, en una intervenció, encara que sigui petita, amb una extracció dental, sí que pots sangrar si tens uns nivells una mica més justets de lo normal. I llavors és recomanable fer-ho una vegada per veure una mica on estàs de cara a poder-te anticipar amb un altre procediment, sigui una extracció dental o sigui qualsevol cirurgia.
D'acord, gràcies.
Just a more general comment to any of the parents out there who have children with haemophilia, or indeed to any of the young men with haemophilia. I think there's something we don't appreciate, and that is that haemophilia gives you a great degree of resilience, because we face challenges earlier in life that many of our friends and peers without haemophilia don't face and will never face. So it actually gives you a strength and a resilience that can be very beneficial throughout your life. And I find myself now with, I've got friends without haemophilia who for the first time in their lives are coming up against health issues. And they're terrified, they can't cope with this. They're horrified by something fairly simple. Whereas we tend to, I've always felt that many of my friends with haemophilia and a lot of my friends with haemophilia, we don't sweat the small stuff. We don't worry too much about the little bits and pieces of everyday life that can be major stresses for other people. So I think in many ways haemophilia can help you develop great coping mechanisms for life itself.
El doctor Parra quiere hacer una pregunta. Bueno, sí.
Hola. Sí. Ha estat clar que Hemlibra és un fàrmac amb molt bons resultats i que hi ha certes dificultats per la seva administració o implementació dels malalts. Llavors he preguntat a Automàcris si sap si hi ha altres molècules similars a Hemlibra que estiguin en desenvolupament i que això, si es comercialitzen, puguin afavorir o disminuir el preu i fer més fàcil la seva administració.
Someone told me there are 5 other molecules like Hemlibra in development. I'm not sure whether they'll all reach patients, but there is one called MIM8, MIM8, that is already in clinical trials, including in Barcelona. So if a product is in a clinical trial, you're talking about 2 or 3 years away in terms of being available. And the way the market works, if you've got more than one product, the price will come down when it's introduced because of competition.
The price will come down if you've got a system that allows that to happen. In the USA, even though we've had EHLs and Hemlibra, the standard products that have been on the market for many years, the price has remained high. It hasn't gone down because their system is such that it doesn't allow for this. So I think, I agree. I think if and when MIM8 is licensed, it should put price pressure on Hemlibra. I recall that we paid a relatively high cost for many years for the only recombinant factor 9 on the market. As soon as the second standard recombinant 9 came on the market, the price went down significantly. So it won't automatically go down, but I would always start a conversation by saying, now we're going into a procurement process. You now have a competitor on the market, so you basically, they won't offer to lower the price, but it should be part of the process.
Bé, bueno, és una pregunta una mica tècnica, però aprofitant que està aquí el doctor Macris, li vull fer. Quan un nen que neix amb hemofília comença el tractament, s'ha de començar a donar factor 8 en un moment determinat per prevenir el desenvolupament d'inhibidors, que això es diu toleritzar. El pacient no ha tingut mai contacte amb el factor 8 perquè no en té, i si se li dona massa tard o en una cirurgia hi ha més risc d'inhibidors. Clar, ara s'està donant d'una manera molt precoç l'Hemlibra perquè no cal posar un portacaz, un catèter per posar el tractament, i això és molt bo perquè els nanos ja comencen a córrer, no tenen problemes, però hi ha el debat científic de si cal, a més de l'Hemlibra, anar donant factor 8 per buscar que no hi hagi més risc d'inhibidor. Això no es coneix que és la millor opció, però m'agradaria saber la seva opinió.
There is no answer to your question because nobody knows. However, there are clinical trials that are going on with newborns giving just Hemlibra and treating bleeds with factor 8, or giving Hemlibra with regular factor 8 and see if it makes a difference. The true answer will come. We will know, but at the moment we do not know if it's necessary. If you've had a previous inhibitor, we do not know whether it's necessary when you're having Hemlibra, whether you need to have a low level of regular factor 8, like small dose once a week to keep the inhibitor away. Our approach, I don't know if it's good or bad, it has been when patients are started on Hemlibra is not to give regular factor 8 and deal with it if the inhibitor appears.
Aquí al nostre estat el més freqüent és donar factor 8 quan es comença amb l'Hemlibra. Com que no hi ha resposta, ho dic perquè si algú coneix o té un fill que li passa que li estan donant les dues coses, que pensi que això és una qüestió que encara no està clara i no se sap quina és la millor, a veure en els propers anys. Ja està. Bueno, sembla que l'Oti diu prou.
Bueno, jo crec que podem estar contents, no? Moltíssimes gràcies a tots pel vostre esforç, per la vostra dedicació, i ara ens agradaria, anirem a fer el jardí, una mica de pica-pica, que és on podrem parlar, vosaltres podreu parlar amb els metges, amb els amics, amb tothom, però abans ens agradaria fer una foto amb què sortíssim tots. Aleshores, us demanarem que us poseu aquí al davant, la càmera es posarà aquí i sortirà tot el públic, no només vosaltres, sinó vosaltres amb tot el públic. Us sembla bé? Doncs vinga. Ei, gràcies a tothom i ens veiem al jardí.